So very good evening, doctors. We are on live, sir. So I'm Dr. Stalin on behalf of Shield Healthcare, welcoming you all for the today's webinar. On behalf of Shield Healthcare, I would like to thank the Aurangabad and Yavatmal Society for giving us this opportunity. Before starting the session, I would like to welcome Dr. Sonali ma'am to give the welcome address.
So good evening, good afternoon, everyone. My best wishes for this CME, and I extend my warm regards to all the speakers, and I'm eagerly waiting for them. I'm thankful to Dr. Pardesi sir, Dr. Ajay Mane sir, convener of the CME, Yavatmal ObGyn Society, and Aurangabad ObGyn Society. So now, right now, I am having one meeting. That's why I am leaving. I will again join after 15 or 20 minutes. Thank you.
Yes, thank you, Sonali madam. You are a MMC observer and very good friend of all of us, and you are working at such a big place, that is Government Medical College. We appreciate all your efforts.
Thank you.
Thank you very much.
Thank you, Sonali ma'am. Thank you.
Thank you.
Yes. So now I would like to welcome the organizers for today's session. Next slide, please, Chitra. So I would like to welcome Dr. Anuradha Shivale ma'am. Madam is the president of Aurangabad OG Society. Madam is currently the clinical director at Ajanta Fertility Center in Shivale Hospital, Aurangabad. Madam is the consulting obstetrician and gynecologist, founder member of Maharashtra chapter ISAR, member of Aurangabad OG Society, member of IAGE, ISAR and ESPAT, fertility training from Vadia Maternity Hospital and laparoscopic training from PC Mumbai. And Madam has attended various national and international conferences. Madam has various publications to her credit, like Clinical Study to Knowledge Etiological Factors Causing Male and Female Infertility in AMOGS 2012. And Madam, as the third party IVF gives high success rate from at Shivale Hospital 2016, patient-friendly IVF experiences at IVF Center AICOG. So we welcome you, ma'am. And I would like to welcome the next organizer, Dr. Vishali Mane ma'am. Madam is the president of Yavatmal ObGyn Society. Madam is the recipient of Maharashtra Jana Gaurav Puraskar by the Governor of Maharashtra at Raj Bhavan, and executive member of Adolescent Health Committee, Foxy 2019-21, recipient of Rakshamai Raut Award for Best Clinical Services in year 2017, recipient of Nari Gaurav Puraskar by Child and Women Welfare Committee, presented various papers in national and state conferences, winner of Best Paper Award in AMOGS Conference 2019, contributed one chapter in Foxy Focus, and Madam has authored in Foxy FAQ Adolescent Health published recently. So we welcome you, ma'am. And I would also, I would like to welcome the next organizer, Dr. Yogita Sopate, ma'am. Madam is currently the director, Mahalakshmi Multi-Specialty Hospital, Yavatmal, and secretary of Yavatmal ObGyn Society. Now I'd like to welcome Dr. Next slide, Chitra. Gurpreet Kaur, ma'am, and Madam is the secretary of Aurangabad ObGyn Society 2021 and 22. Consultant at CSMSS Hospital, Multi-Specialty Hospital, presented papers in international journals, presented papers in Foxy and International Congress, contributed articles in Foxy newsletter, executive member, ISC, Imaging Science Committee, executive committee member, IEC, organizing secretary, Sonokon at Aurangabad 2019, practicing in Aurangabad since 15 years. So we welcome you all, ma'am.
Thank you.
Now I would like to welcome the conveners for the day, Dr. Ajay Mane, sir. Can I have the slide, please? Sir is the member of National Inspection and Monitoring Committee, Government of India, medico-legal consultant since 18 years, and sir is giving advice of free of cost, and chairperson official AMOGS website, chairperson Sexual Medicine Committee, chairperson Adolescent Health Education Committee, joint secretary AMOGS Maharashtra State Association of ObGyn, past secretary Aurangabad ObGyn Society, national trainer of Foxy Adolescent Health Committee. Sir has 9 national and 4 international publications, authored topics in various Foxy Focus and various books. ex-superintendent MGM Aurangabad, Medical College Aurangabad, and medical advisor for Sports Authority of India, chapter president Rotary Club of Aurangabad, LA. We welcome you, sir. Now I take to my pleasure to invite Dr. Next slide, Chitra.
Girish Mane.
Yeah, Girish Mane, sir. Yeah, Girish Mane, sir. Sir is the chairperson Adolescent Health Committee, Foxy 2019-21. Sir was the past president of Yavatmal ObGyn Society, past chairperson Adolescent Gynecology Committee, AMOGS 2018-20. Sir has received the best chairperson AMOGS 2018-20 and recipient of Foxy Smriti Mailan Save Baby Girl Runner-Up Award, recipient of Best Society Award of AMOGS Award, recipient of Durisha Youth Trophy and Dr. Sadhana Desai Award in 2017. First winner of Foxy Talent Singing Contest, contributed 5 chapters in Foxy Focus, presented many papers in national and state conferences. Sir is the editor of Foxy Focus, Adolescent Intervention for Future Reproductive Health, and editor of AMOGS Focus, Adolescent Healthcare. So we welcome you, sir. Now I am handing session to Dr. Ajay Mane, sir, for taking it forward.
Yes, thank you, Dr. Stalin. At the outset, I must welcome all the faculties and delegates. Particularly, I'll name them. First and the foremost, Dr. Rajan Singh Pardis, sir, who is my mentor. Then Girish Mane, my brother, and Chairperson Foxy for Adolescent Health Committee, Dr. Andhra Shawale Madam, Gurishali Mane Ma'am, then Yogita Sopate Ma'am, and Gurpreet Kaur, who are President and Secretaries of Aurangabad and Yavatmal ObGyn Societies. Then Chairpersons, Pardisi Sir, Anjali Vare Madam, who is incoming President of Aurangabad ObGyn Society, Dr. Aparna Rao Ma'am, Vice President of Aurangabad ObGyn Society, and Harshalata Ladda, who is a renowned infertility specialist in Aurangabad. Then the most renowned speakers, Dr. Gorakh Mandrupkar from Islampur, Dr. Amme Purandare from Mumbai, Dr. Megha Kalmapurkar Ma'am, basically from Maharashtra, now in Karnataka, and Dr. Manisha Patrikar is a renowned speaker from Aurangabad and IVF specialist in Aurangabad.
Hello, just 1 minute. Dr. Ajay, after just welcome Dr. Nandita Palchetkar ma'am. And
Is
after your
Great.
talk, yes, and just invite her to give blessing for our webinar. Okay?
Yes, obviously, we need that. And I welcome Aurangabad Yavatmal ObGyn Society, all delegates, Dr. Stalin from Steel Connect. And thank you very much. Now, the most happy moment of our webinar is there. Dr. Nandita Palchetkar Madam, who is the president of AMOGS, and our elder sister is here, all with us. Thank you, Madam, for being there in spite of your busy schedule, it seems. And I welcome you, and I request you to give us the blessings as an opening remark.
Ajay, thank you. Thank you so much for inviting me. I think, Ajay, all the best, and you are an amazing person. I'm really enjoying all your academic deliberations a lot. And I must congratulate Anuradha and Vrishali for doing this programs together. And I think the whole essence of our Foxy, of our AMOGS, is working together, collaboration. And I think as a Foxy president, I always believe that, different collaborations actually value add. So I think it's an amazing thing. And under the guidance of Dr. Pardesi, who's going to take over AMOGS now, I think we're all very excited, and I am so happy to come here. And I think Girish and Ajay have done a great job, and I'm sure the CME will go fantastic. All the topics are really wonderful and very useful and practical topics. But remember one thing, I think right now what we need is fellowship. So all these CMEs, everything is helping us update our knowledge for the betterment of the women, but also it brings about a great sense of fellowship. And as obstetricians, I think, we need quality of life. As we want quality for our patients, we need quality of life even for the doctors. So I think in obstetrics, if we do group practice, this is what I always talk about, I think group practice will give you quality of life, especially husband and wife, Vrishali and Girish, if they work together, they get better. One can go, but then if they both want to travel together, they should take on somebody else. I think it's very important that you have somebody to share your, problems, to share your happiness, everything. And I think we gynecologists should realize that the times are changing. My younger generation wants quality of life. So I think it's time we move towards working together and collaborating together, just as, Aurangabad and Yavatmal has done this program together. I think we need to form alliances and work together and really enjoy our profession, give it our best, and get the best out of it for ourselves also. So thank you very much. And thank you for inviting me here, Dr. Pardesi. It's always a pleasure to be here with my Maharashtra. Thank you.
Thank you, madam.
Thank you,
Thank you.
ma'am. Thank you.
Sir, Ajay sir, you're on mute, sir.
A minute. Thank
Yeah.
you, Nandita ma'am. Thank you very much for the blessings. And you are always there for all of us. We know that you are always there.
Totally with you.
Yes, ma'am. Thank you. Thank you. Over to Dr. Stalin.
Yes, sir. So, sir, I would like to welcome the chairpersons for the today's session. We will go for the first chairperson, Chitra. First slide, please. So I welcome Dr. Anjali Vare ma'am. Madam is currently the consultant at Vare Hospital, Aurangabad. President-elect, Aurangabad ObGyn Society. Chairperson, Critical Care, ObGyn Sonocon 2019 conference at Aurangabad. Volunteered at IMA Corona OPD 1. We welcome you, ma'am. Now I would like to welcome the next chairperson for the day, Dr. Radhar Singh Pardesi sir. Sir was the VP Foxy 2019-20, VP AMOGS 2022, and President of AMOGS 22-24. Sir has 27 papers presented in 20 national and 7 in international conferences. Sir has received the 6 times Best Paper awardee in Foxy's AICOG conferences. Was faculty in AOCOG 2011, Type I, and in Bangkok. And sir was the faculty at FIGO 2006, Kuala Lumpur, and FIGO 2012 and Rome, Italy. Was the chairperson of Food and Drug Committee, Foxy 2012 and 14, awarded Dr. Ansotia Best Committee Award. We welcome you, sir. And I would like to welcome the next chairperson for the day, Dr. Aparna Raul ma'am. Madam is practicing ObGyn consultant since 22 years. Advanced training in reproductive endocrinology and ART from Bad Mundur, Hanover, Germany. Madam is core fertility specialist at Aurangabad International IVF Center. Received Young Scientist Award at AICOG, Hyderabad and Siliguri in 1996 and 97. Received Young Gynecologist Award in Asia Oceania Congress, Malaysia, 1998. We welcome you, ma'am. We'll go to the next chairperson for the day, Dr. Ashalata Lada ma'am, and madam has done her MBBS DGO fellowship in artificial reproduction technology, presently attached with Samrat IVF Garikat, Aurangabad. Madam has done her MBBS from MGM Medical College, Aurangabad, DGO from Mumbai University, and madam has a fellowship in ART CAMAR Edapal, Kerala. We welcome you, ma'am. Now I would like to welcome the next chairperson for the day.
Stalin, there are only 4 chairpersons.
Yes, sir. Sir,
Yeah,
if you allow us, then we
start
can go for the first scientific session, sir.
Yes.
Yes, sir.
Please
So
go.
the topic for the first session is medical management of PPH. Now I'd like to welcome the speaker for the day. Chitra, next slide, please. I would like to welcome Dr. Manisha Kakade Pratikar ma'am. Madam is currently the director and consultant obstetrician, gynecologist, fertility specialist, endoscopic surgeon, and WHO IARC certified colposcopic at Anastri New Spring Fertility and IVF Center, Aurangabad. Madam is the vice president of Aurangabad ObGyn Society, organizing secretary at Sonocon National Conferences 2019-20, received Best Society Awards of AMOGS 2018-19 during secretary AOGS. Madam is the president of Lions Club of Aurangabad Angels 2021. Madam has received various media awards like Times of India, Maharashtra Times Appreciation of Appreciation Award for contribution towards development of Marathwada region 2021, and Divya Marathi at 94.3 FM at Women's Achievers. So we welcome you, ma'am. I'm handing session to you for your presentation, ma'am. Thank you, ma'am.
Welcome, Dr. Manisha. Manisha, you are muted. Yeah.
Thank you so much for your kind introduction, Stalin sir. Thanks, Dr. Pardesi sir, for giving me this opportunity. Thank you, Mane sir, Ajay Mane sir, Girish Mane sir. Thank you, Anuradha Shivaya madam, President AOGS. Thank you to Vishali and also the secretaries, Yogita and Dr. Gurpreet, for giving me this platform to share my views on the medical management of PPH today with all of you. Thank you so much. Not taking much time, I would like to start my presentation. Are my slides visible?
Yes, ma'am.
Yes, ma'am.
Okay.
Can you please make it in slideshow mode? Thank you, ma'am.
Okay, so I would like to start with a note by Brent McGill. Just beyond the horizons of the so-called impossible is infinite possibilities. And that is how our patients look up to the obstetricians when PPH is concerned. And firstly, we will start with the MMR. Now, what is MMR? MMR is a ratio of the number of maternal deaths during a given period per 1 lakh live births and during the same time period. And it is used to measure the quality of healthcare systems. Now, global and national goals for MMR were that WHO Sustainable Development Goal to reduce the global maternal mortality ratio was to get it less than 70% by 2030. And India has just missed it in 2017 National Health Policy target to achieve this MMR of less than 100. Now, let's see the figures. In 1990, it was around 567, which has dropped down decades after decades. And in 2020, we are so near, that is 101. And only 5 states in India, like Kerala, Maharashtra, Tamil Nadu, Telangana, and Andhra Pradesh, have achieved the target of MMR less than 70. So this shows that we have come a long way from MMR 567 to 101 by 2020, but still there is a long way to go. And why and how have we achieved this goal? So through a project success, by planning, communication, skills, tools, processes, management, and teamwork. And the contributors for decline in the MMR are the government schemes like JSY, which came up at 2005, and JSSK at 2011. And increase in institutional delivery rate up to 70%. This has merely chiefly helped to decline the MMR, actually. And the training of skilled birth attendants, training of MBBS doctors, new uterotonic drugs like carboprost around 1980, and misoprostol, which was launched in 2010. And the community-based advanced distribution of tablets, misoprostol by ASHAs and ANMs, and aggressive blood component transfusions, which have been used to save lives of women. Now, why are we worried about PPH?
And what is the statistics for this PPH? About 830 women die per day around the world due to cause related to childbirth. And three major preventable causes of maternal death are hemorrhage, sepsis, hypertensive diseases. And every year, about 14 million women around the world suffer from PPH. And the quickest killer is this PPH, and if not treated in 2 hours after the childbirth. Maternal mortality from hemorrhage, 1 in 1,000 deliveries, is in these developing countries, and considerable morbidity is due to the shock, multi-organ failure, anemia, and coagulopathy. What is the postpartum hemorrhage? It's a ringing of alarm, and we all are into a very difficult and panicky situation at times when this PPH sets into our labor rooms. And traditionally, the estimated blood loss is more than 500 ml in the vaginal deliveries and more than 1000 ml in the cesarean deliveries. And AICOG 2017, the cumulative blood loss less than 1000 ml with the signs and symptoms of hypovolemia within 24 hours of birth process, irrespective of route. RCOG says that the minor is when it is 500 to 1000 ml, and major to moderate is if the blood loss is more than 1000 to 2000 ml, and severe is if it is more than 2000 ml. What arrests this bleeding physiologically? Now, vasoconstriction of the uterine vasculature that occurs after the birth, which is also called as the living ligatures. Here, the myometrial contractions occur, and the retraction, approximation, and pressure of the uterine walls takes place, and the clot formation occurs, and this clot stabilizes in open uterine sinuses. Then we will see the different modalities of management of this PPH. Now, medical, we will see oxytocin, carboprost, methylergometrine, misoprostol, transaminic acid, recombinant activated factor 7, and minimally invasive and supporting. There are bimanual uterine compression, internal uterine tamponade, non-inflatable anti-shock garments, and pelvic packing. And surgical, the hemostatic uterine sutures, stepwise pelvic devascularization, uterine artery embolization, endovascular balloon occlusion of aorta, hysterectomy, and repair of lacerations and tears of the birth canal. And today we are chiefly going to study about the medical modalities for the management. Here is another quote which was appropriate for this by Charles Babbage. And for one person who is blessed with the power of invention, many will always be found who have the capacity of applications of these principles. What is new for management of PPH? It is carbetocin, transaminic acid, vacuum-induced suction tamponade devices, intrauterine balloon tamponades, selective arterial embolizations, aortic compressions, vaginal ligation of uterine artery, surface sealants, and external uterine pressure tamponade. These are all the new come-ups, and we are going to study carbetocin in more detail. It's a long-acting, heat-stable synthetic analog of oxytocin. And up to its action lasts up to 60 minutes if given intravenously, and 120 minutes if given intramuscularly. And the dosage is 100 micrograms per ml as a single dose after delivery of the baby. And route is intravenous bolus injection over 1 minute intramuscularly. And the contraindications: preeclampsia, eclampsia, severe cardiovascular diseases, hepatic and renal impairment. Now, what works? What are the updates that WHO recommends, and which one should be the choice of uterotonic for the PPH prevention? Let us study. The first recommendation that WHO has come up is that the use of an effective uterotonic for the prevention of PPH during the third stage of labor is recommended for all the births. And to effectively prevent the PPH, only one of the following uterotonics should be used, that is oxytocin, carbetocin, misoprostol, ergometrin, or methylargometrin, and oxytocin plus ergometrin in a fixed dose combination. Now, one by one, let us see. For oxytocin, the recommendation is that the use of oxytocin 10 international units, either intramuscularly or intravenously, is recommended for the prevention of PPH for all the births. And this could be vaginal birth or a cesarean birth. Skilled health personnel are required to administer, and at cesarean section, consider dividing the dose and avoiding the rapid IV bolus. Then we see carbetocin. The recommendation for this is that WHO recommends the use of carbetocin 100 micrograms intramuscularly or intravenously, and is recommended for the prevention of PPH for all the births in the context where its cause is comparable to the other effective uterotonics. And it is used for PPH prevention only. Then misoprostol. And the recommendation is that the use of misoprostol, either 400 micrograms or 600 micrograms orally, is recommended for the prevention of PPH of all the births. Alternative route may be needed at cesarean section, but oral route is preferred by many women. And no clear evidence of which dose is superior, but higher dose have more side effects. And firstly, we have to inform the women of possible adverse effects as well, and can be used in the hospital and community. Now, what are the recommendations for the ergometry? It is use of ergometry 200 micrograms intramuscularly or intravenously is recommended for the prevention of PPH in context where hypertensive disorders can be safely excluded prior to its use. Then the mixed one, that is oxytocin and ergometry with fixed dose combination. And here, the recommendation is that the use of oxytocin and ergometrin fixed dose combination, that is 500 international units of oxytocin and 500 micrograms of methylargometrin given intramuscularly, is recommended for the prevention of PPH in context where hypertensive disorders can be safely excluded prior to the use. Then we have injectable prostaglandins. And injectable prostaglandins, that is carboprost or selprostrol, are not recommended for the prevention of PPH. How do we compare the uterotonics to one another? So oxytocin is the current standard of care. Larger number of trials in the network and meta-analysis have come up for this drug. So oxytocin always stands standard in the care. And the natural sequence for introducing a new uterotonics option is to evaluate the efficacy with the gold standard option. Now, how do the effect of carbetocin compare to oxytocin for these outcomes? Now, here are a few things that the criteria should be fulfilled. And we will study it in the further charts as well. So these criteria were considered by the GDG for each eutotonic options, that is the desirable effect, undesirable effects, then the certainty of the evidence, values, balance of the effects, resource required, and certainty of the evidences, cost effectiveness, equity, acceptability, and feasibility. And with this oxytocin, many studies are there, so many references are there, and hence all the drugs can be compared to the oxytocin as a reference competitor. So if you see carbetocin compared to oxytocin, similar desirable effects are seen, and carbetocin likely is superior in reducing PPH. 41 fewer events per 1,000 women are noted, and use of additional eutotonics, 74 fewer per 1,000, and blood loss after birth, that is 81 ml less on an average. No clear difference in undesirable effects was seen, and while balance of effect probably favors the carbetocin, the supply cost of carbetocin is approximately 20 times more than the oxytocin. But the balance of effect probably favors the carbetocin. This is what we have to remember. And uncertain whether the additional benefits justify the additional cost of routinely implement in carbetocin at the current unit price, and acceptability among the stakeholders and impact on the health equity would vary across setting compared with the oxytocin. And as I said before, this carbetocin is stable at the room temperature, whereas oxytocin we need to refrigerate and keep. Now, misoprostol, when compared to the oxytocin, misoprostol has similar desirable effects to oxytocin, but it has less effective for reducing severe PPH, that is, where the blood loss is more than 1,000 ml or 700 more events per 1,000 women are noted, and causes more undesirable effects, including nausea, vomiting, shivering, fever, and diarrhea. Misoprostol is cheaper, it is heat stable, and can be used orally, and is probably accepted and feasible to use. And the lower effectiveness of severe PPH and greater undesirable effect may increase the cost. These costs may vary according to the settings, and can be the task shifted to lay health workers and community health workers as well. Ergometrine and methyl ergometrine as compared to the oxytocin. No clear evidence of difference is seen in the desirable effect. However, women are more likely to experience nausea, vomiting, headache, hypertension, and diarrhea with the ergometrine. And the cost associated with managing the undesirable effect, as well as need to screen the high blood pressure, implies that oxytocin is probably more cost effective. And ergometrine may have negative effect on health equity in setting with high rates of or lack of screening for hypertensive disorders. Oxytocin plus ergometrine compared to the oxytocin only. Now, similar to oxytocin in terms of desirable outcome, though it is possibly more effective in preventing PPH, more than 500 ml of blood loss and 44 fewer events per 1,000 women were seen, and more undesirable effects than oxytocin, including nausea, vomiting, and diarrhea. Balance of effect clearly favors oxytocin only, and the cost related to undesirable effect, as well as the need to screen the women with the hypertensive disorders, implies that oxytocin is probably more cost effective when compared, and may have a negative impact on health equity, particularly in settings with limited capacity and capability to routinely screening for hypertensive disorders of pregnancies. Misoprostol plus oxytocin compared to the oxytocin only. Now, probably superior to oxytocin for blood transfusion, Fever events per 1,000 women, that is only 11 were noted, and additional uterotonic use and blood loss, 88 ml less on the average, may possibly prevent more PPH and result in smaller mean changes in the hemoglobin levels. Associated with more undesirable effect including nausea, vomiting, diarrhea, shivering, and fever, and balance of effect favors oxytocin, and cost effectiveness may vary in different settings, and feasibility is limited due to the complexity of using two separate medications through different routes of administrations. Now, so recommendation 2, that is, in settings where multiple uterotonic options are available, oxytocin 10 international units intramuscularly or intravenously is the recommended uterotonic agent for prevention of PPH for all the births, vaginal births or cesarean sections. Skilled health personnel are required, and combination of misoprostol and oxytocin may be more effective than oxytocin alone for some priority outcome, however. And this also has been noted that there is increase in side effects, not available as a fixed dose combination, and requires parenteral and oral administration. Recommendation 3. The settings where oxytocin is unavailable, the use of other injectable uterotonics like carbetocin, or if appropriate, ergometrin, methyl ergometrin, or oxytocin and methyl ergometrin fixed dose combination, or oral misoprostol is recommended. And the recommendation 4 is that in settings where skilled health personnel are not present to administrate this injectable uterotonics, the administration of misoprostol, either 400 micrograms or 600 micrograms orally or by community healthcare workers and lay health workers, is recommended for the prevention of PPH. If skilled health personnel are not present or have not been trained to administer injectable uterotonics, oral misoprostol is preferred. Now, what is the new wider scope and more evidence? Uterotonics considered in 2012 recommendations were oxytocin, misoprostol, ergometrin, and oxytocin plus ergometrin in a fixed dose combination. And in 2018, the recommendations were oxytocin, carbetocin, misoprostol, ergometrin, oxytocin and ergometrin fixed dose combination, injectable prostaglandins, and combination of misoprostol plus oxytocin. Now, the evidence-based said that individual Cochrane systematic reviews were given by this 2012 recommendations, and in 2000 recommendations came from the Cochrane systematic review and network meta-analysis, and individual Cochrane systematic reviewers, and one qualitative evidence synthesis of women and providers respectively. And the systematic reviews of cost-effective studies. Now further, this is again a detailed, more recommendations and the greater specificities to the studies. And these are all the same things, but sum up in the one single slide. So let us check the implementing the update WHO recommends. Are skilled health personnel who are administrators of the injectable uterotonics available? If yes, is the oxytocin available? If yes, is oxytocin available in sufficient quantity? If yes, then use oxytocin 10 international units intravenously or intramuscularly. And now, if the skilled health personnel are not there to administer these injectable uterotonics, then the trained community health workers and lay health worker can administer misoprostol in 400 or 600 microgram orally. And if the oxytocin is not available, then in those conditions also, oxytocin is not available or quantity is not there, quantity cannot be guaranteed, then in these conditions, heat stable carbetocin 100 micrograms intramuscularly or intravenously in contexts where its cost is comparable to other effective nutrotonics, or ergomitrin can be given 200 micrograms intramuscularly or intravenously in context where hypertensive disorders can be safely excluded prior to its use, or fixed dose combination of oxytocin and methyl ergometrin in context where hypertensive disorders can be safely excluded prior to its use, or even misoprostol can be given, that is 400 micrograms or 600 micrograms orally. And the take-home messages are to avoid the distress of PPH, predict, prepare, and prevent is the ultimate trio, and identification of high-risk cases and their institutional deliveries is very, very important, and it is must. And active management of third stage of labor by also training of medical and paramedical staff is also important. And prevention of PPH with carbetocin is really a magical remedy, as it is heat stable and its effects are near to oxytocin, being an oxytocin derivative. Thank you so much for patient hearing.
Thank you, ma'am. Thank you very much, ma'am. Now I'm handing to, I welcome Mr. Our Dr. Ajay Mane sir to take over the questions from the chat.
Thank you, Manisha. It was very nice deliberation by you, and you are a typical teacher. A great deliberation by you.
It was a very nice talk. Manisha, she
Thank
has
you so much,
explained
sir.
very nicely each and every drug and their effects. Thank you. Thank you so much. It was very
Thank
nice
you so
talk.
much, sir. Thank you
Yeah,
for
I request
appreciation.
chairpersons if they want to add something. Anjali madam or Aparna ma'am.
Manisha, it was a very good lecture. You have covered all aspects. Only one thing I want to ask, have you used carbetocin personally? Have you
Yes,
any
ma'am.
experience about carbetocin?
Yes, ma'am. I've started using very recently, not since a long time I'm using it, but I've got good effect of it.
Okay.
And I'm happy because it's
Yeah, carbetocin is very good, as Manisha said. But the drawback is that you can give only one dose. You cannot repeat, as oxytocin we can repeat. No, we cannot repeat carbetocin. The only one dose is there. Vrushali, what is your position? Yeah, Vrushali,
yes, sir. So we are using since last 2-3 months. Even my society members, they are giving a follow-up over this injectable. Only one thing clinically which we are facing is hypotension. When we are giving it in a bolus, patient is
in few
getting
patient it is there.
yeah.
You can give in 100 ml of normal
Intramuscular.
saline.
Yeah. Ma'am, that's why now what they started, they are diluting it. Previously, it was said to give complete bolus dose. Now they are recommending off the record that dilute the drug and give it
Yes.
slowly for up to 1 minute. Then the incidence of hypotension is comparatively lesser.
Yeah, as Anjali madam said, it is better to give in 100 ml.
100 ml.
NS.
That's it.
That is the best policy. Okay. Thank you, Vrushali. Thank you, Anjali madam. Thank you, Manisha. Great. Over to you, Stalin.
Yes, sir. So we'll go to the next topic for the day. The next topic for the day is Ask the Expert for Medico-legal queries. I would like to welcome Dr. Next slide, Chitra. Yeah, Dr. Ajay Mane, sir. So as I have introduced previously.
Yeah, it has already been done.
Sir. So I welcome you, sir. I am handing session to you, sir. For your
Thank you. Thank you. Thank you very much. I'll start my presentation. Just let me know, is it working? Just a minute. Because now I have just loaded Mandrupkar sir's because his internet connection is a bit unstable. So he sent me, okay, now I upload mine. Yes. Is it seen?
Yes, sir.
Yes, sir.
Yes. Thank you very much. Thank you, Pardesi sir, Anuradha madam, Vishali, Jopate ma'am, Gurpreet, and chairpersons. We'll go fast. We're late. I got few questions from the delegates, and somebody said on WhatsApp group. Those questions I have compiled in one presentation. So, do we need to change our MTP registration certificate from approved authority? I changed from 20 weeks to 24 weeks. Now, the change has taken place on the 2nd of October. Everything is implemented. And as myself and Dr. Pardesh sir, we had a discussion with Dr. Archana Patel madam for Maharashtra. She's Director of Health. She said there is no need to change, as it is given in Gazette that the word 20 weeks must be replaced by 24 weeks. That's all. No need to change the certificate. See, that is the provision by our director. But if some appropriate authority, say for an example, in Aurangabad, the MOH, Medical Officer Health, the Chief Medical Officer of Aurangabad Corporation, has invited the old certificates, and he asked the members to kindly submit and get a new certificate on which the 24 weeks is mentioned. Likewise, they can do. No charge is to be there for the renewal or rather replacement of the certificate. But if the approved authority says you need to follow that, but as per law, there is a no need to change the certificate. Fine. Next question. Can we terminate pregnancy after 24 weeks and maybe after 28 weeks? Yeah, this is in the recent amendment of MTPs. After 24 weeks, see, they have allowed us or permitted us, which previously was up to 20 weeks, 12 to 20 weeks to opinion, and we can terminate. But now 1 to 20 weeks, one opinion, and 20 to 24 weeks, two opinions. And if the pregnancy goes beyond 24 weeks, then we need to approach to the medical board. The medical board is being formed at all district levels by the appropriate authority of state, of each state. Okay. And if the pregnancy goes after 20 weeks, 28 weeks rather, that again, in that case also, we need to approach the medical board, because in law, they have mentioned that after 24 weeks, we must go to board. But up to which week, they have not mentioned. So every case beyond 24 weeks goes to medical board. Okay. Then, and there is one exception for that. If a rape case is there, MTP is allowed for a rape case up to 24 weeks. And if it goes beyond 24 weeks, it does not go to medical board. We need to go to High Court and onwards. Okay, that is the only provision. After 28 weeks, we go to medical board, and the provision in legal matter is that 500 grams onwards, if the fetus weight is more than 500 grams, then we hand over it to the relatives and kindly get a received copy from the relative that we got the fetus, dead fetus, and have the footprints with you, and received the name, the signature, time, and left thumb impression. Because many of our colleagues have faced a big problem because the receipt was not there. I have helped 2 or 3 of them, 4 of them, and 3 are now free of the allegations, and 1 is still facing the problem. We are in court. Okay, but please take a receipt from them. That is the solution. Question: is failure of contraception available after 20 weeks up to 24 weeks? See, failure of contraception was available for only married couple up to 20 weeks in previous MTP law, but now they have opened it for the unmarried also. Okay, the failure of contraception is available up to 20 weeks only. No beyond 20 weeks is allowed for the purpose of failure of contraception. Okay. Question: in case of a USG performer is different, can a owner of the USG center sign the report? Basically, a owner can be a non-medical person. Okay, and routinely not accepted as per the law, because the sonologist or the radiologist or the gynecologist who is performing the sonography must sign the report and the declaration, both. Okay, but recently Honorable Supreme Court allowed in one case as administrative in charge can sign and give report in that case only, but the USG must be done by the registered sonologist only. In this case, the sonologist left for an emergency and the report was to be printed. So the administrative in charge had signed and gave the report to the patient, but it is not a law. The Supreme Court has considered on various basis and they have given the verdict, but it is not the law. It is routinely not accepted. Okay. Then what next? Is USG mandatory before MTP? No, not by law, not mandatory by law, but my advice is to have a USG before any MTP, medical method or surgical method. Particularly medical method is very ambiguous because you know it is a, sorry, whether it is intrauterine, whether it is extrauterine or it is heterotropic, tubal, then cornual, whatsoever, what not. And you are giving the medications and rupture and shock. We have seen so many cases. Okay, so next question is it mandatory to mention missed abortion, incomplete abortion, inevitable abortion, and blighted ovum in MTP register? The question was incompletely sent. Okay, is it mandatory to mention it in a form 3 or the MTP register? And shall we have the form 1 and form C? The answer is no. Why? Because in the right to information, we have sort of information from Government of India that it is not under MTP. So the records of the obstetric complications, these are the wordings from Government of India. The records of obstetric complications, including incomplete abortion, inevitable abortion, missed abortion, blighted ovum, are required to be kept by all health facilities. However, form 1 and form C, it is not form I, it is form 1 and C under MTP regulations do not have to be filled for these complications. The records of these complications have to be maintained in the appropriate facility records, but not in the MTP register. Clear? Fine. In Maharashtra, we need to have a separate information as a natural abortion. And on before 5th of every month, we are giving the information to the appropriate authority in form 2. So there we need to fill 2 forms, one for routine MTPs and one for natural abortion. The separate column is there. What are the natural abortions? These are the natural abortions. We need to mention the numbers in that question. Okay, correct? Question. Which are the documents in PCPND? In short, they are form A, certificate application, B, certificate of issued, form C, reason for refusal, form D, for genetic counseling center, form E, genetic laboratory where chromosomes are separated, form F, genetic clinic, we are all feeling that. Then form G, consent for imaging procedures, amniocentesis, etc. And form H by authorities where all the instruction or the information of the registered centers is gathered. Tell in detail about the form F in PCPD. And who has said this? Okay, I have given the answer. For whom to be filled form for whom to fill form F? For all patients undergoing scan who are pregnant. Many of the gynecologists or the obstetricians we have seen while our NMNC visit and all regular inspections that for routine follow-up purpose, they put the probe on the abdomen of the woman and they don't fill their form. Don't do that. Please don't do that. Every time you put the probe on a pregnant woman's abdomen, you need to follow the PCPNDT rules and regulations and need to fill the form F online and have a print. Okay, please, this is my request. Pregnancy with age less than 18 years comes under purview of POXO Act and we need to inform the police under which your hospital comes and the police station. You need to inform them in writing and get a receipt from them. That is all. That is your duty, that you must inform. That's all. You need not wait for the police for the further proceedings, or you need not ask the permission from police to go further. Okay, just you have to inform. And if you don't inform, 6 months imprisonment is there. Mind it. Next, when to fill form F? Section A before starting. Section A can be filled before the scan. Section D, declaration should be signed by the patient before undergoing the scan, and remaining F form to be filled after scan is complete and then signed by doctor. But fill the F form completely before going inside the room and just keep vacant the column of sorry, diagnosis and complete the form as soon as you come out of the room. Okay. How to fill form F? Section A, B, C, D. Section A, general. 8 points, name, address, everything. Section B is non-invasive, that is for sonography. Indications, 23 indications, 24 is any other. If some special investigations is there, you can mention it in them. Covers most of them as NT scan, targeted scan likewise. And section C is for invasive procedure. We are not doing invasive procedures. Fetal medicine people, they are doing. And from section D is declaration by both. Okay. Copy. How to scrap old machines? That is again a tricky question. Previously, no provision was there, but amendment in 2003 they have done, and in recently they have formed the body and all the things. Machines should be sold to registered centers. This is the amendment, because we cannot sell a machine to anybody who is not registered under the Act. Okay, and what is the scrapping policy came in 2019? Abandoned machines must be handed over to the appropriate authority with a receipt for the purpose of condemnation and scrapping. You should have that receipt. Okay, मुझे एक machine Dr. Ajay Mane की तरफ से मिला. Thank you. Afterwards, whatever they wanted to do with the machine, and what is their procedure? They need to form a committee under chairmanship of appropriate authority at all district and corporation level for this purpose. That is amendment in 2019, and they may dismantle it or do whatever they want with the technical personalities. That is not our headache. Just we have to hand over the old machine to them. Okay. Question: what are the penalties under violation of TCP Act? Yeah, it is cognizable, non-bailable, and non-compoundable. I'll explain the word. Cognizable means even a case has been registered by the police. No court shall take cognizance except the complaint. Okay, fine. Action 2. See, non-bailable means what? There are two types: bailable, non-bailable. In both cases, you get the bail. But in non-bailable, you need to go to the court and then you get the bail. And in bailable, you get the bail from the police station only. Say, for example, you have been arrested or taken by the police on Friday evening, but the court is not there for Saturday, Sunday. You need to stay there for 2 days in Chowki, and they will present to you to the magistrate on the Monday morning or the next day morning, and then you will get the bail. That is a non-bailable. But if you get the bail at the Chowki level only, that is a bailable. Cognizable means where the investigating officer can start the investigation on his own. He or she do not need the order from the magistrate. That is a cognizable. Non-cognizable is they are simple offenses. NC police says like that. And cognizable is dangerous. And non-compoundable. Once a case is filed, the two parties, they cannot say, okay, hamara jam gaya abhi, court Maharaj, respected magistrate, so we are settled now, so we want to withdraw the case. Not possible in non-compoundable. If it is compoundable, it is possible, but this is not possible in non-compoundable. MTP and PCP are non-compoundable. Okay. What is the difference between PCP and MTP? Okay. One consultant may have many centers as well as can go to many centers for MTP, which is not possible in PCP. Only 2 centers till today in one district. If you are staying on a border, you can have 2 centers in 2 districts, but the time must be displayed at each and every center. Okay, and we have to follow that. One may perform MTP at any recognized approved centers in India. See, for example, one person who is having a MCI recognized degree or diploma of the obstetrics and gynecology or all the things, they can go to any MTP recognized centers and perform the MTP. If they are going out of state, they need to inform the state medical council that will be performing the MTPs here. That is the only procedure, but you are allowed. No regular inspection mentioned in law. In PCP every 3 months they need to inspect the center, but in MTP that is not mentioned. No renewal, like PCP every 5 years we have a renewal. In MTP, no renewal is there once lifelong registration is there. Place approved and not restriction on persons to perform MTP. MTP, I can go to Pardisar, I can go to Manisha's hospital and perform MTP, but I cannot go there and perform sonography as my name is not there registered at the PCP. Okay. The non-bailable cognizable I told you. Rigorous imprisonment 2 to 7 years with or without fine. Fine. Thank you. Those were the questions. Thank you very much. My gratitude to Rajan Singh Pardisar as my mentor. Dr. Girish Mane, my bandhu, Chairperson Foxy. Dr. Anada Shewale Madam, Vishali Mane, Dr. Yogita Zupati and Gurpreet Kaur Sandhu, President and Secretaries. Then Chairpersons Pardisar, Anjali Ma'am, Apna Raul ma'am, and Harshalata Ladda. Speakers, Dr. Gorak Mandrupkar sir, Dr. Amay Purandare sir, Dr. Megha Kamlapurkar madam, and Dr. Manisha Patrikar Kaplay madam from Aurangabad. Aurangabad and Yavatmal ObGyn Society, all delegates, and particularly Dr. Stalin from Shield Connect. Thank you very much. If needed, I am always there, a phone call away for any kind of medical help that is free of cost. For whole India, I am doing this since 18 years. And this is woman empowerment we required. Mother, a woman is always a mother for whole life, carrying the baby and carrying gun for their protection. This is Indian women empowerment. Dr. Captain Deepashika Chetri, she is at present serving at China Glacier. For nation, she has carried a gun, and for the colleagues, she is carrying a stethoscope. So salute to the Captain Deepashika Chetri and the greatest army of the world, that is Indian Army. And salute to these workers. They are multi-purpose workers or the lowermost chain of the health system, and they are going to the base level, grassroots level, and vaccinating. We have done 150 crores or worth 60 crores rather, but to be more particular. See, she's sitting with a small baby of 6 to 7 months, carrying a vaccine carrier, the kids, and maybe a assistant or husband and baby, and in a run, she is sitting there. Salute to these health workers. And this is my sincere request to you that kindly, please nominate me and vote for me for the Foxy West Zone. There are 2 places for the Vice President. Kindly vote one for myself, Dr. Ajay Mani. Thank you very much. And if they can stay together, why can't we? So kindly help your colleagues, and the colleagues will help you in your bad times. Okay, thank you very much.
Thank you, Dr. Ajay Mane. We are always with you in your Foxy election for Vice President Foxy, and all Aurangabad, Yavatmal Society, they are all with you for your election, for your Foxy Vice President West Zone. Thank you so much.
Thank you, sir. Welcome, Amay Purandare, sir, and welcome, Megha Kamlapur, ma'am.
Thank you. Very well done, Dr. Ajay Mani.
Thank you, ma'am.
Thank you very much.
Ajay. Amay Bandhu, please. Thank you.
Stalin.
Yes, sir. Sir, is there any questions from the chairpersons? If there is no questions, then we can go for the next topic.
Yes.
Yeah. Next topic.
So we can go for the next topic. Recent updates in recurrent pregnancy loss. Chitra, yeah, I would like to welcome Dr. Gorak Mandrupur, sir. Sir is the consultant at Islamabad, Maharashtra, was the Joint Secretary Foxy 2014-15, was the Chairperson of Medical Disorders of Pregnancy 2016-18, Office Bearer of Gestosis of India, has published 7 publications to his credit, and sir has authored various chapters in books. His focused work in gestosis score in gestosis. He has worked with NGO Samyak and proved linkage of MTP Act with PCP NDT in against women's health and reproductive insights. And sir is acting as the advisor, medico-legal advisor for 24 hours. I welcome you, sir. I'm handing the session to you for your presentation, sir.
Okay. Thank you very much. So at the outset, I thank Yavatmal Society, Aurangabad Society, and mainly Pardeshi sir for inviting me in today's seminar. That and he has given me opportunity actually to read again and again. And always I'm very much thankful to sir that he gives me topics बदल के. आणि त्यामुळे इट इज व्हेरी गुड की खूप वाचावं लागतं. आणि आय एम व्हेरी मच थँकफुल सर की ऍक्च्युली आय वॉज प्लॅनिंग टू रीड रिकरंट प्रेग्नन्सी लॉस इन सो मेनी डेज अँड अगेन आय हॅव टू गो थ्रू इट. सो थँक्यू व्हेरी मच. अजय माने सरांनी बॅटिंग केल्यानंतर रिअली इट वॉज फंटास्टिक. And I think, sir, this is a very nice style of presentation where he has given the questions and the answers. Because otherwise, everybody knows the law and many things, but there are a number of questions which are there in our minds, and sir has tried to give the answers to all of them. So now I will share my screen. The topic given to me is what is new in this, but unfortunately, एक minute, right. Is my screen visible?
Yes, sir.
Yes, sir.
Right. Okay. And am I audible? Right. So
Yes.
समजा जर टाइम ओव्हरशूट व्हायला लागलं तर मला मध्ये थांबवा, काही अडचण नाही. आय एम सॉरी. सो recurrent pregnancy loss, when we think, I have tried to, what we say, give justice to the topic which is given to me. The topic given to me is recurrent pregnancy loss, what's new. Fortunately to say and unfortunately to say is there is nothing new. Only thing, there is a revisit to the topic and how one should understand what is the difference between recurrent pregnancy loss and what is the isolated that abortion. Because when we utter the word pregnancy loss, if it is for that instance, then the investigations will be different. One has to understand why this abortion has occurred in this case. So the scenario might be totally different. And when we are thinking of recurrent pregnancy loss, that means already the patient has 2 STJs or 2 miscarriages or 2 abortions or 2 loss of pregnancies. And now she has come in front of us. And now she is urging that I should get investigated. So how we should see to such case, that is very important. So the exact prevalence is difficult to estimate, but most of the studies, they report that it affects 1 to 2% of the world women. Now, what are the high risk factors? So when we see the high risk factors, increasing age, of course, I always say in my OPD that भारतीय बायकांच्या बाबतीत 15 ते 35, म्हणजे आता 15 म्हणायचं नाही, पण अदरवाईज 21 ते 35, this is the ideal period. त्यात सुद्धा 21 ते 30, 21 to 30 is the ideal period of pregnancy. And because, see, when we have started developing the follicles and when we are going to end them up, so this period is of fertility. And it should not, never, always, one thing we have to keep in mind, it should not be always minimum, maximum. It should be optimum. So whenever there are optimum number of follicles, optimum age, optimum size, optimum BMI, optimum hormones, everything, that is the ideal period when one should try and have the babies. Is there association of stress? Yes, definitely there is association of the stress, but when it was done a study, whether stress causes recurrent pregnancy loss, then no association was found. Maternal weight, yes, both extremes. As again I was saying, too small, too big, it causes a problem. So underweight, obese, definitely there is RPL. Smoking and alcohol, yes, in both partners. Many one might think that smoking, alcohol, the newer habits in the modern society. But yes, it has been seen that even the habit of smoking and alcohol in a male partner, that has also given rise to the recurrent pregnancy loss. So from all these points of view, the couple should be counseled. When such couple comes in front of us, ideally one should handle the couple and not only patient. Detailed medical history, because the detailed menstrual history may give rise, revisit and give the concept of care. Probably she might have thyroid disorder. Obstetric history is very important. One must ask and one must see the papers thoroughly whether this was those both the losses, whether they were blighted over or whether it was missed abortion, spontaneous abortion, what was the gestational age, what were the events, whether she was fine, fantastic one day, especially in the second trimester abortions, and suddenly she started leaking, whether it was associated with pain, without pain, whether it was associated with trauma, with lifting of the weight, etc. Because even the events of each abortion, they are going to give us some ideas. Medical disorder history. One must ask ki आई, मावशी, आजी, बहीण, काका, आत्या, मावशी, आजी, दोन्ही बाजूला, whether they have VTE, venous thromboembolism, thyroid, thrombophilias. History suggestive of SLE, diabetes, chronic asthma, chronic anemia, chronic anemia. Because this is going to give us some ideas, some clues. Previous uterine surgical history, not only family, but even the medical disorders in that individual mainly. And then comes the family. Previous uterine surgical history, how many times you have undergone the DNE, or even there are still many people who are doing DNC for the infertility. As a Sakari, one patient has come, she has asked me, sir, all investigations are normal, pishvi tevdi doon deta ka? I can't do that. When there are good hormones, when we have sonography, when we have hysteroscopy, there is no necessity to do all these things. But yet there are certain people who are still doing all these things. So even the Asherman, that can cause the recurrent pregnancy loss. Very important thing that when we are doing the sonography, here as respected sonologist is here, all seniors are here, they will agree. One should write a report properly whether my sonography has shown a blighted ovum or it was a missed abortion, whether fetal pole was present or not, whether really there is a gestational sac or not, whether there is yolk sac or not, because that is going to give us the correct diagnosis. So when fetal pole is absent, unembryonic gestation, blighted ovum. Very rarely it is recurrent. But if it is recurrent, then we have to think, recurrent blighted ovum is happening. That means probably there is a problem in the male, especially the chromosome number 9 or chromosome number 16 problem. So when one is writing the blighted ovum or missed abortion, has to be very particular what we have seen and what we have written. Otherwise, many a times report shows fetal pole is present, cardiac activity absent, diagnosis blighted ovum. Very wrong. Or unembryonic gestation and niche likha hai missed abortion. Very wrong. You will say, I have so many copies of it, so I am talking. Missed abortion. Fetal pole is present, but cardiac activity is absent. So please write the report, history sheet, discharge card carefully, because when we are assessing the case of RPL, one must understand what are the etiologies. Let us go one by one. Let us start with uterine factors, anatomical defects. Yes, the acquired abnormalities like intrauterine adhesions, myomas, polyps. Intrauterine adhesions or syncytiae, they occur in the sites where endometrial basal layer has been destroyed. Most frequently following the curettage, uterine surgery, infection, complicated birth. And studies have shown that when we do the hysteroscopic adhesiolysis, significantly it has reduced the miscarriage rates, and it is preferred treatment for the women with RPL. Cervical incompetency usually causes second trimester losses, can be acquired following the surgical trauma, or it is associated with the congenital uterine anomaly. Serial transvaginal cervical length measurement, which can be done either by two methods, as Dr. Ajay Mane says very nicely. Either you use the cervical trace method or directly from the internal to external loss, but the cervical trace method is fine. Whenever we are doing sonography, we should have a habit to write the cervical length. Because what will happen? Suppose I am seeing the patient in the 4th month and I have seen the 1st month report, which shows that 6 weeks pregnancy with 3.5 centimeter cervical length. And now I am seeing that this is a NT scan, 12-week scan, and I am finding cervical length as 2.7, 2.8. So that significantly shows that yes, it has reduced. So one must get aware. One can inform the patient, one can be ready for the prevention. Submucosal myomas and uterine polyps, they are reportedly found with RPL and should be removed. I am very precise. What I am talking, submucosal myomas and uterine polyps. Congenital anomalies, yes, they are there in 8 to 12% of the women. Septate uterus, that is the main thing. Otherwise, Usually unicornate uterus, bicornate uterus, usually they do not give. Usually they do not give. Very rarely it can be associated. But septate uterus, yes. Most common type associated with RPL. There is evidence to suggest that improved pregnancy rate following the metroplasty. उगाचच हिस्टोस्कोप आत घातलाय, रिसेक्टोस्कोप हातात आहे म्हणून मेट्रोप्लास्टी बऱ्याच वेळा केली जाते. One should not do that. When there is definitely a surgical, there is a septum, it has to be removed. Finally, it should be noted that for women with RPL secondary to irreversible uterine anatomic defects, gestational carrier. I have not used the word surrogacy because now I am afraid of, since that law has come. So I have used the word as a gestational carrier. Chronic endometritis. Yes, chronic inflammation of the endometrial lining. It doesn't allow the proper implantation, or even if it allows the implantation, it may throw out the pregnancy. And that's why it has been shown that now that chronic endometritis is also associated with recurrent pregnancy loss. And ideally, this can be demonstrated on the immunohistochemistry methods. But yes, most commonly it is infectious. So it is better that one should have the before pregnancy. And in cases of such RPL, vaginal and even the oral, the doxycycline 200 milligram for 14 days, full course in a proper way. If it is done, then yes, probably it has. In many studies, it has shown that it is helpful. Torch panel. Yes, Dr. Amey sir is going to talk on that, but I'm very damn sure that he will really focus on this issue. But when a case of RPL comes, there is no torch. I always tell my all patients, my colleagues, that when I was born, it has stopped. So no torch panel for recurrent pregnancy loss. But if it is a case of isolated abortion, and if you want to find out, fine. But when case is there as a recurrent pregnancy loss, there is no way at all to do the torch. Even if at all to do, sir will definitely tell regarding how IgM is to be done, IgG, what is avidity and all, he is going to focus. So I am not going in detail. There is evidence that bacterial vaginosis may give rise to the abortion, but there is no evidence that it will give the recurrent abortions. So no causal link, no test empirically treat the asymptomatic woman unnecessarily, no torch, and many things they are given wrong. Antiphospholipid antibody syndrome. Yes, the presence of these bodies and pregnancy morbidity is one of the two clinical criteria required to confirm the diagnosis, and other is vascular thrombosis. So one clinical and one lab. Prevalence is generally accepted as 5 to 20%. In my area, it is very common. Again, lupus anticoagulant, anticardiolipin antibody, and mainly anti-beta-2 glycoprotein, and even antiphosphatidylserine, that even fourth antibody should be done, but there is no evidence. So at least these three antibodies should be done. Otherwise, many a times we write APLA, then the report lab gives APLA, IgM, IgG negative. No. All these antibodies should be done. Even Russell Viper RVTT should be done. Lupus anticoagulant, anticardiolipin antibody, Russell Viper venom timing, then even the PTT and all those things, they should come in a proper way, and then only one can diagnose. It has been shown that it is associated with preeclampsia, IUGR, prematurity. So one must be very careful. Do you know how it causes? Actually, these antiphospholipid antibodies, they target the trophoblast. They cause the impaired trophoblastic invasion. They cause the inappropriate secretion of HCG and growth factor. They induce the sensitive trophoblast apoptosis and inflammatory response via complement activation. So this is how they are going to act. So this can be repeated. So antiphospholipid antibody syndrome is one of the important cause and one of the important investigation when you are doing the assessment of recurrent pregnancy loss case. Many therapeutic approaches they were suggested, like aspirin, unfractionated heparin, LMW heparin, corticosteroids, then intravenous immunoglobulin. But nowadays we have come and sustained only with LMW heparin with ecosprin 75 milligram, 75 to 150. Here I can say but 75 milligram will suffice. Heparin can inhibit the antibodies from binding to the trophoblast, prevent the complement activation, and promote the trophoblastic invasiveness. So this is how LMW heparin is going to help. Endocrine factors, yes, they are to be kept in mind. Because if you see from Jammu Kashmir to Kanyakumari, and here you take from Gujarat to Pragjotishpur, that means Guwahati. There is different geographical variation. If you see in Western Maharashtra, we have 22 to 27%. If you go in Telangana, 39%. If you go in Jammu Kashmir, almost 42%. Hypothyroidism is there. So thyroid screening, especially TSH and TPO antibodies, is recommended in women with RPL. For pregnancy, I always say only TSH. But when cases of recurrent pregnancy loss, do both. Because it has been shown that overt as well as subclinical hypothyroidism, they both are responsible for recurrent pregnancy loss, for even hypertensive disorder, and even for intrauterine growth restriction and preterm. Now, whether assessment of insulin resistance, prolactin, LH, androgen, luteal phase, vitamin D, are they to be done for RPL? No. Answer is no. If you are doing the assessment of infertility, that is something different. When you are doing the assessment of recurrent pregnancy loss, these investigations are not recommended. Inherited thrombophilia, yes. In our area, protein C and protein S deficiency, again, I am finding common because we have a series of patients. But otherwise, factor V laden, prothrombin gene mutation, antithrombin 3 deficiency, MTHFR mutation. Myself, I am a case of MTHFR mutation. Again, it is very common. We have done a study and we have found out that yes, so our population now, it is again very high risk. Why it is high risk for developing MI, developing diabetes? This is the reason. So one must always check for this MTHFR gene. It is very common. And त्यामुळे ते होमोसिस्टिनचा प्रॉब्लेम आहे. म्हणजे forget about this RPL, but even routinely MI and all, they are very common. So please, even simple आहे, आपल्या साध्या थुंकीवरती सलाव्यावरती we can check this. We are doing in the pharmacogenomic labs. I do for many patients the pharmacogenetic studies, whether my medicines are going to act on her or not. But yes, I am not recommending it routinely, but yes, it can be done. Screening for inherited thrombophilia is recommended in pregnant women, especially with history of venous thromboembolism. However, directly association with RPL is controversial, but yes, protein C and S deficiency is being found. Now the next is, chromosomal abnormality, genetic causes. Vast, आता हे फार महत्त्वाच्या स्लाइड्स आहेत, या 4 स्लाइड्स. त्यामुळे they are very important. I am going to read line by line because I have prepared them line by line, word by word. And for these 4 slides, I have spent more than 3 days. So please, the vast majority of early pregnancy losses, 50 to 60%, are the consequence of chromosomal abnormalities, which can be of the parental origin or they arise de novo in embryo from parents with normal chromosome. So this line is very important. That means the parents may be abnormal, and so may they give abnormal pregnancy, but at the same time, they may give normal pregnancy as well. But at the same time, even normal parents, they can give the abnormal pregnancies. So that we have to keep in mind. Most common parental abnormalities are balanced translocations, which are found in 2 to 4% cases of RPL. While in general population, this is 0.7%. So that means almost 6 to 7 times high. They are there. But they can be of 2 types. Either it can be reciprocal or it can be Robertsonian. Reciprocal means involving the exchange of genetic material from one chromosome to another. While Robertsonian means the long arm of the 2 acrosomic chromosomes, they incorrectly share the centrosome. म्हणजे थोडासा ह्याचा तुकडा निघून गेलाय लागलाय तर, आणि अदरवाइज अख्खाच्या अख्खा क्रोमोझोम मध्ये काही प्रॉब्लेम झालाय तर, एवढं डोक्यात ठेवूया. The paracentric and pericentric inversions, they are much rarer, but they are also associated. Next slide, very important. All balanced translocations, they can be detected by ordering a peripheral karyotyping in parents. आपण जे साधं routinely लिहितो ना की मला karyotyping पाठवून द्या ते. Parents carrying balanced translocation, they are usually asymptomatic. The karyotype of their product, म्हणजे POC, can be entirely normal or can have a balanced or unbalanced translocation. म्हणजे all possibilities are there. Pregnancies with unbalanced translocations, they usually end in miscarriage, which is often seen as natural selection method. देव मला माहिती नाही तो नेचर जो काय हायएस्ट ऑथॉरिटी आहे तो ते असलं काही ठेवतच नाही तो पाठवून देतो बाहेर. बट कॅन ऑल्सो लीड टू स्टिल बर्थ और इवन लाईव्ह बर्थ विथ मेजर डिफेक्ट. त्यामुळे आपण नेहमी नेचरचा जे काही सिग्नल्स आहेत वी हॅव टू कीप इन अ माइंड टू कॅच देम. It is difficult to estimate the percentage of each possibility because karyotypes on miscarried POCs are not routinely ordered and even not routinely recommended. Last slide regarding genetic. This is very important slide. The incidence of एक minute मला दिसे ना.
I'll read the
एक minute sorry.
अरे तुम्ही पूर्ण
Screen
बाहेर
sharing
जा.
has been stopped. Sorry sorry. काही दिसे ना मला. The incidence of embryo chromosomal
आमच्याकडे स्लाइड दिसत नाही
abnormality.
तुमची. हॅलो आता हा
सॉरी सर एकच मिनिट. आता दिसते सर.
दिसते स्क्रीन शेअर करा मोठं करा.
मोठं करा स्लाइड शो करा.
तेवढं वाचून करतो मला ते दिसते ना जरा. The incidence of embryo chromosomal abnormality is lower in women with RPL than in those with sporadic miscarriages. Very important line. Incidence of embryo chromosomal abnormalities is lower in women with RPL than in
sporadic miscarriages.
Sporadic miscarriages. एकच मिनिट. Data from embryo biopsies report that approximately 25% they have normal karyotypes, confirming the high level of chromosomal abnormalities in these embryos. Confusing. Overall, despite the increased risk of pregnancy loss, most couples with balanced translocation end up with healthy live births. पुन्हा गोंधळ. Embryonic aneuploidy is the most common cause of early pregnancy loss. Indeed, up to 90% of chromosomally abnormal embryos are spontaneously aborted, another natural selection mechanism. And the most commonly found abnormalities are numeric chromosome errors like trisomy, polyploidy, monosomy X, and the risk of aneuploidy significantly increases with maternal age. आता हे सगळं विसरून जाऊया आणि एक वाक्य शेवटचं वाचूया. Because most cases are de novo errors, the risk of an embryo aneuploidy occurring in a subsequent pregnancy is low, and higher the number of miscarriages, less likely they are to be related to chromosomal abnormalities. त्यामुळं त्याचं असोसिएशन हे फार काही मोठ्या प्रमाणामध्ये आहे असं अजिबात नाही. मग लोकांनी सजेस्ट केलं की why not to do PGT. What is that? Pre-implantation genetic testing for RPL. So they have studied what PGT does. PGT involves performing the biopsy on the resulting embryos. की असं होतंय ना चला मग त्यांचा IVFच करूया. त्या घेऊया एम्ब्रियो एक तर 8 cell cleavage स्टेजला or blastocyst स्टेजला. Let us take the biopsy. Embryonic DNA is tested for genetic abnormality, and only the embryos with normal DNA they are later transferred into the uterine cavity. So this was suggested. What happened? Then what? So we talked about PGT. What is PGD? When the genetic defect is already known, such as cases of parental balance translocation, the process is called as PGD. करायचं तेच आहे फक्त नावं वेगळी वेगळी. And what is PGS? काहीच माहित नाही फक्त स्क्रीनिंग करायचं. When no genetic abnormality is identified in the parents, a comprehensive chromosome screening is performed to determine which embryos are diploid टू बी लेटर ट्रान्सफर्ड, त्याला म्हणायचं PGS. हे फक्त टू अंडरस्टँड की PGT टेक्निक, त्याचे PGS PGD, दॅट्स इट, बस. कन्सेन्सस ओपिनियन, दिस इज व्हेरी इम्पॉर्टंट. ही स्लाइड महत्वाची. ओव्हरऑल क्युम्युलेटिव्ह लाईफ बर्थ रेट्स seem to be comparable following IVF PGD or expectant management in couples with RPL and balanced translocations. IVF PGD has decreased the rate of miscarriage and could shorten the time to the first live birth. म्हणजे काही जणांना ते दिसले की बाबा ते गरजेचं वाटते. However, it is an expensive procedure, carries some risk of complications. It could be in itself a source of significant emotional burden for the couple. पैशाचा प्रॉब्लेम आहे, अवेलेबिलिटीचा प्रॉब्लेम आहे. PGD could thus be considered beneficial for couples with high risk translocations by reducing the risk of miscarriages and avoiding a child with unbalanced form. But for low risk translocations, natural conception should be the preferred option, and couples with RPL due to balanced translocation should have a thorough genetic counseling to better assess their future risk and then choose the option they believe is best for them. म्हणजे थोडक्यात पैसे, अवेलेबिलिटी, म्हणजे कमर्शियल थिंग, अवेलेबिलिटी, द नीड फॉर दॅट कपल, आणि या सगळ्याचा विचार करून निर्णय घ्यावा. कारण हे काय 100% खरं आहे अशातला भाग नाही. सो दॅट वी हॅव टू कीप इन माइंड. लास्टली, हाऊ टू वर्कआउट. For years, आपल्याला माहिती आहे की genetic evaluation of the POCs was not routinely ordered because it was considered difficult and unreliable. But previously it was done by routine karyotype analysis. Nowadays, good methods like CGH, म्हणजे comparative genomic hybridization is there. जिथं allowed for 23 chromosome pair analysis. Even single nucleotide microarrays are there. So it is easy. It is easily reproducible, and many referral centers for RPL, they currently start their evaluation of a couple with RPL with a POC karyotype. But sir, probably patient has come for the second miscarriage itself. तर आता ते जेव्हा already 2 are happened and now the couple is in front of us, how we are going to do? It is not possible. So what is to be done in that case? In that case, directly you should go for full RPL workup. CBC, TSH, anti-DPO antibody, त्यानंतर complete anti-phospholipid antibody syndrome panel, ANA, that is for ANA पण महत्वाचं आहे because even SLEs, rheumatoid arthritis, all these things are common in our area and they are giving RPL. So these investigations are to be done. If an unbalanced chromosomal translocation or inversion is found, suppose parental karyotype was ordered, then yes, PGD can be offered. Some studies have reported such strategy to be more cost effective. However, if a POC of karyotype, if POC karyotype is not available, a full RPL workup is ordered. ही बहुतेक last slide आहे. पहा, etiology. If it is a uterine factor, what is the test for diagnosis? 3D ultrasound, sonohistography, hysterosalpingography, hysteroscopy or even MRI. सगळे नाही करायचे, जे गरजेचे आहेत, इझिली अवेलेबल आहेत ते. सेप्टम असेल, हिस्टोस्कोपिक रिसेक्शन, मायोमेक्टॉमी. तुम्ही म्हणाल सगळे नाही करायचे, असं काय वेड्यासारखं बोललात? कारण बऱ्याच केसेसमध्ये मी असं पाहिलंय. आय हॅव सीन डबल मार्करही करतात, ट्रिपल मार्करही करतात, क्वाड्रुपल मार्कर करतात. आता तो 5 मार्कर असेल तर तोही करतील. म्हणजे एकाच पेशंटवरती ऑल इन्व्हेस्टिगेशन आर डन. त्यामुळे कधी कधी हे सांगावं वाटतं. अँटीफॉस्फोलिपिड सिंड्रोम, yes, these antibodies are to be done. Heparin, aspirin is a classic thing. Endocrine abnormality, yes, levothyroxine, prolactin problem, bromocriptine. Diabetes असेल तर control. Genetic counseling, PGD when necessary. Environmental factors, eliminate the toxins. Psychological is unexplained. Yes, psychological support is very important. खूप छान तिला समजावून सांगितलं पाहिजे. अशा वेळेला प्रोजेस्टेरॉन दिला जातो. सर्टन इवन unexplained is progesterone supplementation, immunomodulating treatments. I am coming in the next slide. So what are the new options under the trial? Prednisolone in selective cases of Apla's positive, or SLE is positive and rheumatoid arthritis positive patients. Intravenous immunoglobulin, they are tried, but with caution. For that, in Indian scenario, we have intramuscular in immunoglobulin, which has shown better results every 21 days. Adalimumab, which was TNF alpha antagonist, आता ह्या कोरोनामुळे असल्या औषधाचे आपल्याला उपचार सोपे झाले. It was tried but difficult. Intralipid and GCSF, they have been used but experimental setting मध्ये, otherwise ते नाही वापरायचे. Conclusion: RPL, important reproductive health issue. Various etiologies have been identified. Full workup can be initiated following 2 consecutive losses. Identify the treatable cause. जोपर्यंत आपल्या हातात डायग्नोसिस येत नाही, प्लीज इन्फॉर्म द कपल दॅट नॉट टू हॅव द चाइल्ड. थांबा, इन्व्हेस्टिगेट करूया, ट्रीट करूया, प्लॅन करूया. Empirically, even in some cases, aspirin and heparin has given good result when we have not found any disease. But yes, lifestyle modifications, almost half of the cases still remain unexplained. And regardless of the cause, a thorough follow-up with an important psychological support can help the most couples. आणि शेवटी मी तरी पेशंटना सांगतो की बाबा रे, इथे ह्याला काही एंड नाही. सो कुठेतरी श्रद्धा ठेवा, शांतपणे स्वतःच्या शरीराकडे लक्ष द्या, योगाभ्यास, देन गेटिंग ऑल हॉर्मोन्स ट्रीटेड नॉर्मल करून शांतपणे बऱ्याच वेळेला त्यांना भ्रामरी प्राणायामाचा उपचार दिला जातो. I have a special clinic on RPL, so definitely there is good experience. But I have seen that yes, with Brahmari pranayam, giving good folic acid, vitamin D complex, vitamin D prior to becoming pregnant, good psychological support, and correct diagnosis, and if we follow them, कधी कधी गरज नसताना सोनोग्राफी करावं लागतं त्यांच्या मनाच्या समाधानासाठी. वी हॅव टू टेल देम की ठीक आहे, करूया, 2दा 3दा करूया, डोंट वरी. ऑफकोर्स जसे अजय माने सरांनी सांगितलेलं सगळं फॉर्म बिम भरून, पण येस, आणि मग सायकोलॉजिकली डेफिनेटली वी हॅव सीन ॲट मेनी केसेस दे डू व्हेरी वेल. सो थँक्यू व्हेरी मच. आय एम सॉरी इफ आय हॅव शूटेड द टाइम. लास्टली फक्त एवढे एक शेवटचं रिक्वेस्ट आहे की मेडिकल अँड्रॉइड ॲप्स आहेत हे 2, प्लीज डाउनलोड करा. HDP जस्टोसी स्कोअर, क्रॉस 11 नुसते डाउनलोड करून ठेवू नका, वापरा, बिकॉज इट इज गोइंग टू डेफिनेटली रिड्यूस द मॅटर्नल मॉर्बिडिटी अँड मॉर्टॅलिटी. सो थँक्यू व्हेरी मच अगेन, अँड आय थँक परदेशी सर, अजय माने सर, माने मॅडम, यवतमाळ सोसायटी अँड औरंगाबाद सोसायटी फॉर इन्व्हायटिंग मी अगेन अँड अगेन in the webinars. Thank you very much.
Great, Gorakrao. As usual, it was nice celebration by you, and I'm happy that you have started that project together, which we discussed of Brahmari Pranayam and Omkar Jap. It is working.
Actually, अजय माने सरांनी ही आयडिया दिली होती PCOS च्या पेशंट करता, आणि त्याच्यानंतर when I have gone through the literature, then I found that really it is helping in other cases as well. आपण पण सगळ्यांनी हे करून बघा. कारण कसं आहे माहिती का, बऱ्याच वेळा असं असतं की आपल्याला त्या गोष्टी माहिती नसतात, मग आपण ते योगाभ्यास, आयुर्वेद या सगळ्यांना काहीतरी बंडल आहे म्हणून सोडून देतो. पण तसं नाही आहे त्याचं. वेन वी स्टडी इन डीप आणि त्याचं ऍप्लिकेशन इफ वी डू अलॉंग विथ आवर सायन्स, डेफिनेटली इट हेल्प्स लॉट. आपल्या सगळ्यांच्या स्ट्रेस लेवल कमी करायचे असतील तर डेफिनेटली हे करून बघा. गंमत म्हणून सांगतो, मी काही असा काही फार मोठा तज्ञ म्हणून सांगत नाही. बेसलाईन पल्स माझी खरोखरीच सध्या 58 पल्स आहे. गेली अनेक वर्षेही मी सगळं ट्राय करते. मी त्या सगळ्या डोंगरांवरती पण चढतो, कितीही टेम्परेचरला राहू शकतो, पाणी फार कमी पिणारा, म्हणजे असं हे सगळं अभ्यास करणारा माणूस आहे. 58 बेसलाईन पल्स आहे आणि शरीराच्या रिक्वायरमेंट फार कमी आहे. एकदाच जेवण करतो आणि मग मी हे सगळं करून बघितलं, की डोंगरात राहून बघितलं, हे सगळं करून बघितलं. येस, हिमोग्लोबिन 17 आहे, 16.5 17. कोलेस्टेरॉलच्या लेवल 100च्या आसपास आहेत. माहित नाही एवढं सगळं असून सुद्धा कधी कधी दणका बसतो, पण तरी सुद्धा असं सांगू शकतो हे एवढं सगळं जर पाळलं तर डेफिनेटली इट हेल्प्स. आणि आय हॅव स्टडीड इट ऑन माय पेशंट्स ॲज वेल, आणि मग ते खरं होतं सगळं. सो प्लीज थँक्यू व्हेरी मच. तुमचाही सगळ्यांनी एक्सपिरियन्स शेअर करा. थँक्यू.
Yes, great.
थँक्यू डॉक्टर गोरख. तुम्ही सांगितल्यानंतर मला आठवलं की माझी जेव्हा लॅप्रोस्कोपिक कोलेसिस्टेक्टमी करायची होती, अँड व्हेन आय वॉज टेकन ऑन टेबल दॅट टाइम ही आस्क्ड मी अनेस्थेसियोलॉजिस्ट की तुम्ही ॲथलेट आहात का? तर आय वॉज सरप्राइज्ड. का? नाही युअर बेसिक पल्स रेट इज जस्ट 60.
Yes, yeah.
अँड दॅट टाइम आय कुड रिअलाइज द इम्पॉर्टन्स की आपण करतोय ते चांगलं करतोय. तुम्ही सांगितल्यासारखं प्राणायाम आणि हे ओंकारचं जप रिअली हेल्पफुल.
It was very nice talk, Dr. Mandrupkar, and his practical experiences he shared. It was very excellent. And always his talk is different, and he acts different than others. That's why he's different.
Thank you. Over to you.
One thing I want to add.
Yes, madam.
Sir, male infertility is also very much important in cases of recurrent pregnancy loss.
Right.
So nowadays we are getting a lot of patients with DNA fragmentation.
Yes.
So that also should be ruled out.
Okay. Right. So I purposefully I have not put that slide because I wanted a question on that. Actually, there was a good study on that. When semen analysis was done, even DNA fragmentation was done, and the incidence of RPL was assessed. But it was found that definitely there is no causal relationship was found. But it is said that because DNA fragmentation may be the methodology and the available reports, formats, etc., they are not up to that standard. So it is better to recommend to do the investigations. But depending upon that, do not jump on the diagnosis that there is a problem in these sperms and one should go for donor. Because again, it is said that only one sperm is required for the conception. Let it be IVF, let it be ICSI, or let it be natural conception. So we do not know ki 100% सगळे स्पर्म बाद असतील असं नाही. त्यामुळं there is no recommendation की DNA sperm fragmentation करावं. But yes, madam, you are right. Ki suppose all the factors are normal, then one must study, one must see, and ROS should be treated. That means with good antioxidants, and the male should be treated for that ODFRs, oxygen-derived free radicals. I agree.
Yes, and Gorakhra, we know that the Swayamvar process is there by the ovum. Which sperm to be selected is the choice of that ovum, basically. That
जसं तुम्हाला युनॅनिमसली सगळ्यांनी ठरवलंय की बाबा आता अजय माने सरांना व्हाईस प्रेसिडेंट करायचं. Likewise.
Thank you. Then the choice is of female, basically. Shuddha Bijapoti Rasal Gomti.
In cases of ICSI, the sperm is selected by embryologist.
Ah, yeah, that's true. That's
correct. Yes, madam. It is selected by embryologist.
So that's why.
Literally, after sagla te nasib hai na,
natural process. When naturally it goes by natural process, it throws out the bad embryos.
Yes,
What
that's the advantage of IVF and IUI over ICSI.
Absolutely.
Ajay,
thank you very much.
Thank you. Now I invite Dr. Ame Purandare, sir, who is the incoming Vice President of AMOGS and a great son of a great father, Dr. C.B. Purandare, who is basic. Two persons have started AMOGS, one R.T. Pandit sir and Dr. C.B. Purandare sir, and from them we are now flourishing. So that's why I said a great son from a great father. I welcome Dr. Ame Purandare, incoming Vice President of AMOGS from Mumbai. He is a consultant obstetrician and gynecologist, Purandare Hospital, KJ Somaiya Medical College, Sir HN Reliance, Bhatia, Masina, Mumbai Police Hospital. He is the second Vice President-elect AMOGS 22-24. He is Joint Secretary FOXI 2019. He was Chairperson Food, Drug, Medical, Surgical Equipment Committee FOXI 15-17. Then Assistant Administrator FOXI Manyata Project on Quality Care in Safe Childbirth. Then Member Managing Committee and Mentor Youth Council MOGS. Then Secretary AMOGS 14-15. Then Zonal Coordinator 15-19. State Coordinator 2022. Peer Reviewer Journal of Obstetrics and Gynecology of India, that is Jogi, and awards, so many awards. I'm not going to read because he has given very few. He has got much more than these awards because I know him since his childhood. I have filled his MD registration forms in KEM, I know. And I welcome Dr. Amir Purandare sir and kindly request him to go for the lecture.
Thank you, Ajay, for those kind words. Indeed, it is a great honor for me to be participating in this webinar. Thank you, Pardeshi sir. Thank you, Aurangabad Society. Thank you, Ajay. Thank you, Yavatmal Society, Vrushali, Girish, and all the office bearers of Aurangabad and of Yavatmal Society. It gives me more important pleasure is that this evening I am with the people who encouraged me to take up this post of Vice President and who made it possible to develop a consensus, namely Dr. Pardesi, Dr. Ajay Mane, Dr. Girish Mane, and my dear friend Dr. Gorakh Mandrukar. So they believed, like Ajay said, that unity is strength and AMOGs will always be united. And therefore, Ajay, I think that it is not very far that we will very soon, just like I was elected as AMOG's Vice President, you will be elected as Foxy Vice President. So
Thank you.
I think I'm very positive about it, very confident about it, and I'm sure that it is going to be a reality very soon. Dr. Pardesi asked me to speak about infection in pregnancy, and I thought he will ask me to speak about COVID. Sir is always a very positive person with a very positive outlook. Probably he realized that this COVID wave is going to go away, and we have to start thinking about what we were thinking before, and that is torch infection. So I think that is the reason why he wanted me to speak on torch infections in pregnancy. I'm starting my slide share. I hope you can see it. Ajay?
Yes, we are seeing.
Yeah.
Yes, started, done.
So Professor John Oxford, one of the leading virologists of the world, said, we have come from a world of infection. We live in a world of infection, and in future, unless we take control now, we will continue to live in a world of infection. He said this many years back, before the world had even not even thought about the corona pandemic. I'm going to call it torches infection because we need to think beyond torch as far as the infections are concerned. And I'm actually going to present before you cases of infection in pregnancy and see how torch is to be managed. So torches stands for toxoplasmosis, others rubella, CMV, herpes, that is HSV, and syphilis. The fetus is very important and immunologically capable as the cell-mediated and humoral immunity begins as early as 9 to 15 weeks of intrauterine life. The primary fetal response, just like adult response, is IgM antibodies. There is also a passive immunity which comes from the mother, which is the IgG response and occurs across the placenta and starts by about 16 weeks and increases rapidly. By 26 weeks, the fetal concentration is equal to the maternal concentration, and breastfeeding is protective against some, but begins to decline by 2 months after breastfeeding practices begin. So the first case we are going to talk about is a Gravida 3 abortion 2 with 8 weeks pregnancy. She has a cat and a dog as a pet, and there are no other medical and surgical history except that she has undergone 2 abortions, and therefore, like Gorakh said, in spite of us now knowing that there is no role of torch in RPL, she has undergone the torch panel. The torch panel prior to pregnancy shows that all IgG are positive, namely rubella, toxo, and CMV. We need to counsel her. That means that she is immunocompetent and well protected. Herpes is negative, and all IgMs are negative, telling her and explaining to her that there is no acute infection, active infection, or recent infection. At 12 weeks, a USG was done with the NT and dual marker normal, but the IgG toxo antibodies showed a 4-fold increase. The question that comes to our mind is, do we need to think beyond IgG and IgM? What is the toxo avidity test And do we need to forget everything and just go ahead with an MTP? Toxoplasmosis, the rate of infection is dependent on these two triangles, which one is placed with tip up and the other is inverted down. As you see, the transmission rate goes on increasing with advancing trimester. But thankfully, the rate of severe sequelae goes on reducing as the trimester advances. That means in first trimester, smaller number of babies will get affected, but if affected, will cause greater amount of damage as compared to third trimester, where the transmission rate is greater, but the affection rate is usually negligible. So we do a combined approach of tests, which is called as the TSP or the Toxoplasma Serology Profile, IgG and IgM to begin with. We take the help of IgG A, E, and also the avidity tests. So if both are negative, it means there is no evidence of prior exposure. If IgG is positive, but IgM is negative, that means she is infected prior to pregnancy. If IgG is negative, but IgM is positive, we need to take a confirmatory test. And if both are positive, again, we need to do a confirmatory test. So what will be the confirmatory test? It is the last in the list, that is the avidity test. And I will talk a little bit about this avidity test. A high avidity test result in the first 16 weeks of gestation essentially rules out a recently acquired infection. On the other hand, a low or equivocal IgG avidity test result cannot be interpreted to mean that the patient has recently acquired toxoplasmosis, since low avidity antibodies may persist for more than 5 months. Why is this so important? Because confirmatory serology testing for toxoplasma antibodies reduces induced abortion rates by 50% among pregnant women reported to have IgM toxoplasma antibodies. So the third alternative, that was MTP, is an absolute no-no. Toxo is not an indication for MTP. So then what is the therapeutic alternative? We all know it is spiramycin, but we need to understand where it is indicated, where does it act, and what dose and duration is to be given. The oral dose is 1 gram to be given thrice a day. That means 3 grams per day. It does not cross the placenta reliably. There is no evidence that it is teratogenic, and therefore, as it doesn't cross the placenta, it is only indicated for pregnant women suspected to have or diagnosed with acute toxoplasmosis during the first trimester and early second trimester. It should be given until delivery unless diagnosis of fetal infection is highly suspected or established. So friends, if the fetus is infected, spiramycin, because it does not cross the placenta reliably, has got limited role, in fact, negligible role. Spiramycin needs to be continued throughout pregnancy, even in those patients with a negative amniotic fluid PCR result, because the theoretical possibility that fetal infection can occur later in pregnancy from a placenta that was infected earlier in gestation. For pregnant women in whom the possibility of fetal infection is high, or it has been established, spiramycin should be switched to pyrimethamine, sulfadiazine, and folinic acid after 18 weeks of gestation, because all these have got fetal effects in the first trimester, and hence we need to be safe and hence give it after the 18th week. At 24 weeks, this patient showed placentomegaly, unilateral mild ventriculomegaly, hepatomegaly, intracranial calcifications, ascites, and polyhydramnios. Obviously, it means that the baby is infected, and the question comes to us, should we do amniocentesis or chordocentesis? The most reliable method to detect or exclude fetal infection during gestation is obviously amniotic fluid PCR. Amniocentesis should be done at 18 weeks or more, and the amniotic fluid testing for toxo-PCR should be avoided at less than 18 weeks because lower sensitivity and higher risk of fetal injury. Monthly sonography is also recommended for women suspected or diagnosed as having acquired acute toxoplasmosis during pregnancy. Chordocentesis has been abandoned because of the higher risk of injury and the lower yield for diagnosis of congenital infection when compared with amniocentesis for PCR examination. So to summarize, in a pregnant woman with diagnosis or suspicion of having acquired acute toxoplasmosis during the first 21 weeks of gestation, give spiramycin, but if fetal infection is there, switch over to pyrimethamine, sulfadiazine, and folinic acid. In the loading dose, pyrimethamine of 100 milligrams per day in 2 divided doses for 2 days and then reduce it to 50. Sulfadiazine, again, you have a loading dose and then a maintenance dose. And don't forget folinic acid in a higher dose, especially because both pyrimethamine and sulfadiazine can cause fetal effects. Let's move on to the next case, and that is of rubella. 29-year-old primie gravida, married for 5 years. Cycles are regular. On 25th March was her LMP. On 20th March, just before her LMP, she got fever, generalized rash, occipital lymphadenopathy, and malaise. This was in 2009, so Corona was not there. That if it was presently, we would have all thought COVID and otherwise, and started doing antigen, PCR, mother, father, husband, dog, maid, neighbor, everybody. So in any case of fever, we need to be rational. We need to think what will be the probable cause. In 3 days, that is on 23rd, the fever subsided, rash reduced, and she missed her period in April. It was confirmed by pregnancy by both beta HCG and sonography. So what does the clinical picture suggest? Obviously, there's an infection, there is a rash, and there seems to be the infection around the time of conception. The incubation period for rubella is 12 to 23 days. It's mild fever, rash, conjunctivitis, malaise, sore throat, occipital lymphadenopathy. The infectious period is for 7 days before to 7 days after the onset of rash. So the rash should be documented properly. It begins on the face and spreads to the trunk and limbs and disappears in the same order. And up to 50% of cases may be asymptomatic. Would any test be advised or needed to clarify the diagnosis? Serology is important. Just to put it in perspective, when we did the IgM on 21st, pre-conception, IgM was positive. By May, that is at 6 to 7 weeks, IgG became positive. IgM was still positive, but it has reduced in amount. Ultrasound confirmed the viable pregnancy on 11th May. What confirms the diagnosis of primary rubella infection? Diagnosis of maternal infection is by ELISA, and this is done by doing the IgG and IgM levels, which are convenient, sensitive, and accurate. The presence of rubella infection is diagnosed by a 4-fold rise in rubella IgG between acute and convalescent serum specimens. A positive serologic test is obviously the IgM antibody. A positive rubella culture may also be done, but not practically done by us in most cases. Serology studies are best performed within 7 to 10 days after the onset of rash and should be repeated 2 to 3 weeks later. Avidity testing is vital, and a high avidity indicates a long-standing antibody. Hence, it means that there is an old infection, probably more than 6 months old. Then why are we so worried about rubella in the early first trimester? The risk of congenital rubella syndrome is as high as 90% when it occurs in the first 12 weeks. Then it comes down to 33%, and you will see that after 16 weeks, usually the risk of congenital rubella syndrome is negligible. Congenital rubella syndrome, we have all been told the 3 C's: microcephaly, cardiac defects like PDA, and congenital cataracts, which form the congenital rubella syndrome. But what is important to note, more than 60% of these babies will have sensory neural deafness. 20% will have cardiac defects, and the next speaker will be talking about cardiac defects and their prognosis. Ophthalmic defects are also noted, and CNS defects are also noted. So it is associated with significant handicap at birth, and this continues even beyond in the form of growth hormone deficit and behavioral disorders. What would you then advise this primary gravida? The question she asks you, should she continue the pregnancy or should she opt for termination? what you need to do is counseling. You need to tell her that there was confirmed preconceptional rubella infection. As conception occurred around 12th of April, the usual course of rubella infection where the incubation period is about 2 to 3 weeks. Fever, rash, and lymphadenopathy comes after viremia. The maximum risk of viremia is before the symptoms, and transplacental transmission occurs during viremia. In her case, conception was on 12th of April, was 3 weeks after the rash appeared. Viremia disappears once the rash appears. The virus may persist in the nasopharyngeal secretions maximally for 2 weeks after the rash. In the index case, by all calculations, obviously conception happened after the recovery, and hence we can counsel her and predict a reasonably safe outcome. So how do you manage exposure to rubella? Obviously, you will first do an IgG level. If IgG is positive, she is immune, stop any further investigation. If IgG is negative, then you need to find out when the rash occurred. If the IgM is positive and or the IgG levels are 4-fold increase, there is acute infection and she is at high risk for CRS in the first trimester, you need to counsel her appropriately. If you don't know the IgG levels, you need to ask her whether she was vaccinated. And if she was vaccinated, probably she is immune. You do the IgM levels. If the IgM levels are negative, then you need not worry. You need to reassure her. But if the IgM levels are positive, that means she has not seroconverted. Unfortunately, the vaccination has not been effective, and you need to counsel her for a high risk of CRS because she has acute infection. How do you diagnose CRS? It's with the help of ultrasound. And like I told you, you look at cardiac defects, you look at ocular defects, microcephaly, intracranial calcifications, hyperechogenic bowel, and growth restriction. So in this case, the case tells us that we need to go carefully into the chronology of events and the pathogenesis of viral infection and then counsel. Careful counseling and continued good antenatal care is of vital for reassurance. As far as management of rubella is concerned, since the effects of CRS vary with gestational age at the time of infection, accurate gestational dating is very critical to counsel. The diagnosis primarily of the mother is to be done by serology. The pregnant woman who is exposed to rubella or delivers signs or symptoms of rubella, serology testing should be performed to determine the immune status and the risk of CRS. Rubella immunization should not be administered in pregnancy, but can be given postpartum. And women who are inadvertently vaccinated in early pregnancy or become pregnant following vaccination should be reassured that there are no cases of CRS documented in these situations. And women wishing to conceive should be counseled and encouraged to have their antibody status determined and then undergo rubella vaccination if needed. Let's move on to the next case in the torch panel, and that is of CMV. She's a 25-year-old girl, G2P1, first ANC visit at 6 weeks, all ANC reports normal. At 18 weeks, USG and triple marker are normal. And at 22 weeks, there is history of her 3-year-old child admitted to hospital for pneumonia. Serologic tests of the child show elevated CMV IgM. What next should you do? Obviously, you need to test the mother. And the mother's IgG levels are 98 and IgM levels are 2.1. So the patient has got CMV, but she is most likely to be infected by CMV in the first trimester. We counseled the patient, and in spite of counseling about the risk of transmission to CMV to the fetus, the woman still refused amniocentesis and chose serial ultrasound monitoring instead. At 24 weeks, USG showed bilateral thalamic calcifications, hyperechogenic foci in the right side of the ventricular wall, and asymmetric ventriculomegaly more than 10 mm. What is the prognosis when you see this? If there is a long interval between infection and occurrence of USG markers, it can be a good prediction sign. Reflect less aggressive viral infection than present in cases where the USG findings are obtained shortly after infection of the mother. At 28 weeks, when we repeated the sonography, all the same findings were there. There was cerebellar developmental delay, hepatomegaly, and fetal growth was adequate. At 28 weeks, the patient agreed for amniocentesis. Is it really justified so late? The amniocentesis was done, and it showed that the fetus was also positive for CMV, and the CMV titer was 68 IgM. Thrombocytopenia was also there, and the fetal liver enzymes were normal. All possible consequences of CMV infection to the fetus were explained to the parents. When there is suspicion of CMV and the parents refuse invasive diagnosis like amniocentesis or cortocentesis, don't give up. Still, we have monthly USGs in our armamentarium, and they are vital. We should continue them. At 32 weeks, microcephaly was noted. At 36 weeks, enlargement of the fourth ventricle at the expense of the underdeveloped cerebellum was noted. Second and third stage of placental maturity was there, and low quantity of amniotic fluid, that is oligohydramnios, was noted. Patient was admitted to the hospital. Daily CTG was done, and 2 non-reactive consecutive NSTs and the presence of late decelerations, a decision for delivery was taken. There was a dilemma. Should we do LSCS or should we induce the patient, keeping in mind the baby's condition? We explained to the patient and her husband, and they also agreed to do an LSCS. A male fetus was born, 2.8 kgs, height was 50 centimeters. The skin had petechiae and hepatosplenomegaly. Neurological examination was normal. Thrombocytopenia was confirmed. The neonate was given acyclovir for 6 weeks, and presently the baby is 6 months old, of normal neurological status and preserved hearing. So friends, CMV is the most common congenital viral infection. It's the leading infectious cause of sensory deafness and cerebral mental retardation. The estimated risk of vertical transmission in first trimester is 40%. 10% of infected newborn babies are symptomatic at birth, only 10%. 15% of asymptomatic newborn babies will display developmental disorders later, and therefore they have to be closely followed up. DNA analysis demonstrates active viral infection. In pregnancy, the virus affects the nervous system of the fetus, which attributes to early miscarriage or development of a number of defects in the neonate, so that 30% of them die. Unfortunately, in practice, congenital CMV is not susceptible to treatment, and therefore taking preventive measures is required. In pregnant women, it is advisable to monitor and control the activity of the virus by screening in each trimester. Antiviral drugs suppress viral division and facilitate the passage of virus from the active phase to the latent phase. We move on to the next case, and that is of herpes. 26-year-old comes to ANC with OPD at 6 weeks. She has never had any symptoms of vaginal or oral herpes, but her 26-year-old husband has had his first episode of genital herpes during the last year. This data from the paper way back in 1997 shows that 64% of genital herpes during pregnancy is generally unrecognized because it's asymptomatic. And where do they acquire it? They acquire it from a discordant partner. As you see, only 3.1% of HSV, the women were negative, while in 28% of these negative women, the partner was positive. The vital signs were stable. The uterus was 6 weeks, normal vaginal examination, no lesions, no discharge, no lymphadenopathy, no systemic manifestation. Given that the husband has had a history of genital herpes, would you test the pregnant wife for genital herpes using type-specific serology? Yes, of course you would. So who should be tested? Recurrent genital symptoms, annual examination in high-risk individuals, partner with genital herpes at risk of STDs, seropositive patients, and in early pregnancy. So the wife was tested. She was HSV2 positive. HIV was negative. Husband was also tested. He was also HSV2 positive, and HIV was negative. What would you tell this patient about her HSV infection based on clinical results and manifestations and test results? Is she having a first episode or having a primary or non-primary infection? Is it recurrent symptomatic infection or having asymptomatic unrecognized genital herpes? Obviously, she's got asymptomatic unrecognized genital herpes. Would routine viral cultures should be done in pregnancy and recommended? So antiviral suppression in late pregnancy is very important because it suppresses symptomatic reactivation in late pregnancy and therefore prevents cesarean section. When should you do it? At 36 weeks to the time of labor, and the dose required may be probably higher than non-pregnant. These are the antivirals that we usually use: acyclovir, valacyclovir, and famiciclovir. Will this be helpful? If you see this comparative study, acyclovir patients have a lesser rate of recurrence at delivery time. Cesareans required for recurrence or prodrome are lesser, and presence of viral shedding at delivery time detected via viral culture is also 0 as compared to placebo, where it is 5%. This patient had no HSV symptoms during pregnancy. Acyclovir was not taken as no data to support the use of antiviral amongst seropositive without any clinical herpes episodes. At the onset of labor, she reported no prodrome and other HSV symptoms and no lesions. After a 14-hour labor, she delivered vaginally a healthy 2.7 kg baby girl. So the questions that should be asked when you begin labor in these patients is that, is she having prodrome? Is she having symptoms? And does she have lesions? A key concept is that neonatal herpes, 60% of women who acquire genital herpes in the 3rd trimester of pregnancy are subclinically shedding at the time of labor. So if the patient had genital herpetic lesions at the onset of labor, how should she deliver? She should deliver abdominally, as it would eliminate the risk of HSV. She should also deliver abdominally, as it would reduce the risk, not just eliminate, but reduce the risk. And she should deliver vaginally, since abdominal delivery does not completely eliminate the risk of transmission. These are the 3 thoughts that come to mind. Let us see what evidence has to say. ACUG practice bulletin was put forward way back in 1999 and has stood the test of time. It said women with primary HSV should be treated with antivirals. Women at or beyond 36 weeks with first episode, antivirals should be given. HSV positive women beyond 36 weeks at risk of recurrent HSV, antiviral must be considered, as this may not necessarily reduce the chance of a cesarean. If there are no active lesions, no symptoms, no need for cesarean section, give her vaginal trial, and cesarean section should be performed on women with first episode HSV or recurrent HSV who have active lesions or prodrome at the time of delivery. Why? Because it protects against transmission in women with symptoms or lesions at the time of labor. Avoid invasive practices like scalp electrodes, rupture of membranes, obstetric instruments, as they increase the risk of neonatal transmission. But the patient is asymptomatic at the time of delivery. Is it appropriate for her to deliver vaginally? If the patient had acquired genital herpes around the time of delivery, wouldn't she be more or less likely to transmit genital herpes to her baby during vaginal delivery than if she had a history of recurrent herpes? So this is what you need to keep in mind. If she is HSV seronegative in early pregnancy, but the partner is positive, avoid genital to genital or oral to genital contact. Use barrier contraceptives. If she is seropositive and husband is seropositive, again the same approach, avoid genital to genital contact. And if she is HSV2 positive, you need to educate her, suppress with antivirals, examine for lesions, and avoid invasive procedures. We move on to syphilis now. It is caused by Treponema pallidum. It is transmitted by sexual contact. Placental transmission is noted as early as 6 weeks. There is a large decrease in congenital syphilis since the 1990s. You'll go on to see that by 2000, it came close to 0%. But congenital syphilis is known, and 2/3 of effective live-born infants are asymptomatic at birth, but clinical symptoms split into early or late. 2 years is the cutoff. 3 major classifications: fetal effects, early effects, and late effects. Fetal range from stillbirth, neonatal death, and hydrops fetalis. Intrauterine death is noted in 25%, and perinatal mortality in close to 25% if untreated. Early congenital is mainly cutaneous lesions. The baby is not doing well. Hepatosplenomegaly, jaundice, pneumonitis, that is umbilical cord vasculitis, has got periostitis of long bones. Late congenital shows sequelae such as Hutchinson's teeth, nerve deafness, saddle nose, and can be prevented with appropriate treatment. These are the Hutchinson's teeth that we were taught in first and second MBBS. And diagnosing syphilis, you have the screening test, which is VDRL. It is sensitive but not specific. It is quantitative, so can follow to determine the disease activity and treatment response. And we have the specific Tribonibble test, which is the FDA ABS, which is used for confirmatory testing. It is qualitative. Once positive, will always be positive. Both have biological false positive, and we need to do VDRL screening in all pregnant women in early pregnancy because this is easily treated. Confirmed treponema is identified in skin lesions, placenta, umbilical cord, or autopsy. And the presumptive signs are physical examination, CSF findings, osteitis, phenicitis, VDRL 4 times the maternal test, and a positive IgM antibody. The drug of choice has been, is, and will always be penicillin for all types of syphilis infections. Maternal treatment during pregnancy is very effective, overall 98% success. And that's why we need to screen and treat it, because we'll be successful almost all the time. You need to treat the newborn if they meet the CDC criteria. The mom was treated more than 1 month before delivery. Mom was treated with a non-penicillin medication, and maternal titers do not show adequate response. That is, there is less than 4-fold decline. I move on quickly to 2 others which are commonly seen in our practice. One common and one rare. So 37 weeks, uneventful antenatal care, had dinner with friend 2 days back. Friend has developed chickenpox. How will you proceed? History of chickenpox in childhood, varicella IgG testing. If positive, no further treatment. If negative, immunoglobulin against varicella should be given within 48 to 96 hours. So you need to ask her whether she has had chickenpox. If she's had chickenpox, you are relieved, she is relieved, no further treatment. Can varicella vaccine be given? It is an attenuated live vaccine. 2 doses are 4 to 8 weeks apart. Adolescents and adults with no history of varicella can be given. Avoid pregnancy for 1 month. No termination if inadvertently pregnant. Not recommended during pregnancy, and can be given postpartum even during breastfeeding. The patient developed chickenpox. So maternal management is that it's highly infective, so isolation is required. Increased morbidity in adults, and especially during pregnancy. Pneumonia, hepatitis, encephalitis are the dangerous complications, but they are rarely seen. It's rarely fatal. Symptomatic treatment is given. Prevent bacterial infection, secondary infection by giving antibiotic, and oral and IV cyclovir can be given. The patient went into spontaneous labor within 3 days of developing lesions and had a full-term normal delivery. Is there any risk to the baby? If the mother develops varicella 5 days before or 3 days after delivery, that is before the maternal antibody has been formed, there is serious threat to the newborn, and therefore immunoglobulin should be given to the neonate. What if the patient is 16 weeks and develops chickenpox? If infection occurs in the first half of pregnancy, the incidence before 13 weeks of congenital varicella is only 0.4. 13 to 20 weeks is 2%. Chorionhydratinitis, cataract, microphthalmia, cerebral cortical atrophy, microcephaly, mental retardation are some of the problems. Cutaneous scarring, limb hypoplasia, and missing digits are rarely seen. So the treatment, if the mother is isolation and antivirals, if the baby is affected, you need to counsel her, maybe terminate depending upon the severity of fetal infection. 33-year-old KG teacher, Gravida 2, Para 1, Living 1, 18 weeks, previous full-term normal delivery, baby in good health, blood group A positive, dual marker normal, NT scan normal, reported with flu, temperature of 37.5, and recovered after 5 days with paracetamol. USG revealed a single live intrauterine pregnancy of 18 weeks with cystic hygroma, ascites, hyperechoic bowel, and multiple abdominal cysts. Maternal fetal infection was suspected. Acute maternal and fetal parvo B19 infection was confirmed using quantitative real-time PCR of viral DNA via amniocentesis. What would be the further management? Obviously, 2 options. 1, continue the pregnancy and give fetal therapy. otherwise terminate the pregnancy. So the key factor is to look for fetal anemia, and that we do by doing the MCA PSU. Intrauterine transfusion is a therapeutic alternative, and immunoglobulins have been found useful, but the prognosis overall is guarded, and one must weigh the pros and cons and then only think of continuing the pregnancy. So friends, infections during pregnancy can cause maternal and fetal morbidity and mortality. Transmission of infection is by various routes. Maternal defense and susceptibility play an important role. Infection in pregnancy can be due to multiple etiologies with underlying obstetric complications. Infection in the mother can often have trivial symptoms or even none, hence diagnosis is difficult. Infection in the mother is not equal to fetal infection, and fetal infection does not always mean the baby will be affected. The time to provide information to mothers about these infections is in the preconceptional period. Strategic immunization of women either prior or during pregnancy can eliminate or reduce the risk of maternal, fetal, and neonatal infection and disease. Screening therefore should include for rubella, hepatitis B, syphilis, HIV in pre-pregnancy period or at booking. If screening is positive, confirmatory tests for maternal and if indicated fetal infection are essential before intervention is planned, like we talked about the CMV case. Appropriate investigations and management of suspected infections can reduce unnecessary intervention, prevent or decrease adverse outcome, and relieve anxiety. Selection of antibiotics, antivirals, preventive measures, and vaccine protocols are paramount for treating infections in pregnancy. When your environment is clean, you feel happy, motivated, and healthy. Let us bring out babies in healthy environments in utero so that they have healthy environments out in the outside world ex utero. Thank you so much for a patient here.
Great. Thank you, Ame. It was full of knowledge. You are an encyclopedia, my friend. Great. Best lecture.
Thank you.
May is a hardcore teacher. It was really an excellent talk, and each and every condition he has explained very nicely with case presentations. Thank you. Thank you so much, Dr. Ame.
Thank you so much, sir. Once again, I thank Aurangabad Society and Yavatmal Society for this opportunity, and best luck to my friend Ajay. I'm sure the positive result is going to be there very soon.
Thank you, Ame. We all are here due to your father only. Convey our regards to CB sir.
I will definitely.
Yeah. Thank you very much.
Hello, Ame sir. I think, as I said, everybody was knowing torch only regarding the RPL. But now really, everyone has come to know what actually the torch and torches means, and when ideally the investigation should be done, and how it is going to cause or not cause the effect on the pregnancy. Pretty much for such an elaborate thing. And I think, sir, in his tenure, sir, we come out with a small booklet. It tells what to do and what not to do. And I think that will be the great idea. Thank you.
Gorak, thank you for that suggestion. We will definitely try to implement it. But the key to management of any infection in pregnancy is proper counseling and keeping the maternal compartment or the maternal condition and the fetal condition in the realistic situation. There may be times when maternal condition is usually given the priority. There may be times when fetal condition is given the priority. We need to weigh the cons, pros and cons. Like I said, every infection is not serious, but infection can cause serious consequences. Once we rule them out, even though it will be a stormy pregnancy, but we will definitely have a positive outcome.
Yes, great. Yes, great. Thank you, Ame, for the great insights. And I give you the title of your booklet, Torch on a Torch Infection. Yes. Yes. Now we move on to the next lecture. Again, a great stalwart from field of knowledge, Y4 Chambers Heart View, and none other than Dr. Megha Kamlapurkar ma'am. She's a director of Devata Hospital, Gulbarga, Karnataka, in obstetric practice since 20 years, practicing fetal medicine in high-risk pregnancies, has been a faculty in state and a national level and delivered many talks on fetal ultrasound. Sorry. Has presented many papers and poster. Recently presented a paper in 18th World Congress of Fetal Medicine Foundations in Spain in 2019. Fetal Medicine Foundation UK certified in NT and animal scan. Her hospital is Foxy recognized ultrasound training center for obstetricians and gynecologists. She is a vocalist in Hindustani classical music and has passed BA level Sangeet Visharad. Great thing. First center in Kalburgi, Bidar, Raichur areas to offer invasive genetic testing. I welcome Dr. Megha ma'am to her home state, and I request her to start with the deliberation.
Thank you.
Welcome, ma'am.
Thank you, Dr. Ajay. Yes, start sharing this presentation. What happens now? I'm not able to see the uppercase of my screen.
I mean, it's 54th slide. It seems.
No. Uppercase starting from first slide. I'm not able to do that. You just
Like you go back, go to first slide
beginning.
and then share.
You skip the thing.
Otherwise, slideshow start from beginning. Click that start from beginning.
ते जे आहे ना ते that I'm not able.
Ma'am, you can stop sharing your screen, ma'am.
Okay.
Yeah. Now you can go to the first slide.
तुमच्या लॅपटॉपला फर्स्ट स्लाइडला जा आणि मग शेअर करा.
This is okay?
No, ma'am, not seen.
Not seen. Share. Just a minute.
Not seen, ma'am.
Yeah, okay.
Yes, started. But make it a full screen. Yes. Done.
Okay. Good evening, everyone. Respected Pardesi sir, my friend Dr. Ajay Mani, today's faculties, office bearers of Aurangabad and Yavatmal societies, and all the delegates who are still there at the end of this webinar. I'm extremely thankful for having me invited here for today's presentation. आणि मला माहेरीच्या लोकांमध्ये आल्यासारखं वाटतं आणि तो वेगळाच आनंद आहे माहेरच्या लोकांसाठी बोलण्याचा. तर कर्मभूमी जरी कर्नाटक असेल तरी मातृभूमी माझी महाराष्ट्र. मला एक असं वाटलं की एक कार्यक्रम चालू असतो गाण्याचा आणि बरेच जणांचे परफॉर्मन्स होतात आणि शेवटचा गायक गायला लागतो आणि मग ऑडियन्स मध्ये फक्त एकच माणूस उरलेला असतो आणि त्या माणसाला तो गायक विचारतो की अरे तुला एवढं माझं गाणं आवडलं का? तर तो सांगतो की नाही हो तसं नाहीये, तुम्ही जी बसलात ना त्या ज्या सतरंजीवर बसलाय ती माझी आहे, त्यामुळे मला तुमच्यासाठी थांबावंच लागलं. तर असंच काय असं वाटतं?
नाही मॅडम, तसं नाही. स्टील 153 पीपल आर देअर.
तर ऑफिस बेअरर्स आणि few people will be there, but I am very happy I have got an opportunity to share a very important message and motivate our obstetricians to look into fetal heart. आणि त्याच्यासाठी मी हा टॉपिक मनाने निवडलेला आहे की why 4 chamber of heart fails in screening of the fetal heart. Of course, Dr. B.S. Ramurthy is my teacher under whom I got training, and more than any academics, I learned the honesty of ultrasound from him, and whatever I am today, and whatever credit I get, the major shareholder is Dr. Ramurthy sir. So this proverb I like a lot. Sea is common for all. Some take pearls, some take fish, some come out with just wet legs. Like that, four-chamber or four-chamber view is also easy for all, but we get what we are looking for, and we need to know what should we look for. We all know that the four-chamber view was first introduced as the most important plane for screening fetal cardiac, and that was introduced in 1980s. And later, the ISWAG and American Association of Ultrasound in Medicine, they have incorporated other views of great vessels, and they have recommended the segmental sequential screening of fetal heart. But we are going to restrict today for four-chamber view. We will feel that there is a lot of difference in detection in the rate of congenital heart abnormalities, because the population we screen is different. Some people do screen high-risk population, or some people they do screen low-risk population, and that's why there is a detection rate difference in the congenital heart diseases. It also depends upon the level of examiner's experience, the level of examiner's interest in looking into fetal heart. It depends upon the differences in accuracy of postnatal follow-up. How we follow up these cases, how many cases they go for termination of pregnancy, how many cases reach the term, and how we follow up these babies postnatally is going to decide the detection rate of congenital heart diseases in our scenario. Examination throughout the pregnancy, or is it an examination which is just done at that specified time, like a TIFA scan, or is it done at, especially to look into the fetal heart with previous history of having some teratogenic exposure, fetal infection, or diabetes, or raised in fetal scan? That depends. That is going to decide our detection rate about the congenital heart diseases. And it also depends on which heart diseases we include in the congenital heart diseases. Examination of fetal heart, which is specified, versus or examination of the four-chamber view. Some people, they just look into the four-chamber view, screen, and then report. Whereas some people, they do dedicate their time to look into the fetal heart in all the segmental sequential analysis of the fetal heart. And of course, machine plays immense role in the diagnosis of congenital heart diseases. Four-chamber view was really introduced by Lindsay Allen. She is a cardiologist, and she introduced this as a training program for sonographers and sonologists. And then she gave training to them, and then she gave a checklist to them how to evaluate normal four-chamber view in UK. She asked them to refer all those cases which failed to meet the normal criteria of four-chamber view. And surprisingly, it was seen that there was an exponential increase in the number of referrals and concomitant increase in the diagnosis of the congenital heart diseases. So when the sonographers were trained to look into the four-chamber view and just follow that checklist, that has made an immense or enormous impact on the detection of the congenital heart diseases. And this is how we can incorporate, we can have a thought over that for having such programs for our obstetricians. ISWAG studies also has seen that the difference in the congenital heart detection is dependent when it is done as a screening method or when fetal heart is looked in as a fetal echo. So the detection rate when the examination is not targeted at different centers and the teams are not specialized, the detection rate is just 5 to 15%. Whereas when four-chamber view is done with trained personnel and targeted fetal heart, then it is up to 15 to 40%. And when extended examination was done by special trainings at special centers, then the detection rate was up to 40 to 80%, and it has reached now up to 95% in the hands of in the hands of a good practitioner and with good machines. But why there is such a wide range in the diagnosis from 5% to 95%? When we see that, it is due to the inadequate examination where 4-chamber view is not properly acquired. So चलो हरी भरी में देख लिया 4-chamber है, चलो 4-chamber normal बोल के report लिख दो. So this happens, and when this time we may miss abnormalities in 4-chamber when we do it in a very inadequate way. Sometimes 4-chamber view, we do see 4-chamber views, we do see the 4-chamber, we just have few checklist points and we just forget, or we because of time constraints for a busy obstetrician. So that time we may overlook some minor signs in the 4-chamber view, and which may turn up into the serious congenital heart problems. Or there is a reason that the 4-chamber view, when we are looking in TIFA scan or anomaly scan in 18 to 20 weeks, that time that anomaly is not there. And so there are certain anomalies which evolve in 3rd trimester. Like these appear as a 3rd trimester surprises, like rhabdomyomas or coarctation of aortas. These abnormalities, valvular abnormalities, they evolve in 3rd trimester. So it's not possible for us to look into them in 2nd trimester. What happens? Many times we do targeted examination of fetal heart, and still in 3rd trimester we come across such abnormalities. That time it's very difficult for us to face the couple, counsel the couple, but we need to tell them and show them the evidence that these anomalies cannot be diagnosed in 2nd trimester because of their evolution in the disease process. And this is how these points, they are going to help us in counseling the couple. There are certain defects like patent ductus arteriosus or coarctation of aorta, which cannot be seen in prenatal life, that can be detected only in postnatal life. Like secondum ASD example. One patient, I had one pathologist, and then she used to come for a scan. I used to do this. She delivered a baby, and then she told me, madam, there was a hole in the heart. I was very surprised. I was feeling guilty. Did I miss anything? Then I told, asked her which type. Then she told it is a secondary type of ASD. That time I told her that secondary type of ASDs cannot be diagnosed in prenatal life. So this is how we also need to know which abnormalities are possible to diagnose in prenatal life, and according to that, before we embark upon the fetal echo, we need to discuss the limitations and usefulness of fetal echo with the patients. Certain anomalies cannot be detected by mere 4-chamber views. There are certain anomalies where 4-chamber view will be absolutely normal, but anomalies, major abnormalities like TOF, tetralogy of Fallot, TGA, or DORV, they are common arterial trunk. These will have absolutely normal 4-chamber view. Unless we look into other views, we'll not be able to pick them up by mere 4-chamber view. And this is how, if we don't embark upon the other views, then there is a very high chance that we may miss these abnormalities if we overlook the other views of the fetal heart. So these things we cannot act upon. We cannot. So what are the things which can be improved? It is the inadequate examination where 4-chamber is not properly acquired. What we can do, that we'll discuss. Or if we are able to see 4-chamber view, but in hurry because of our time constraints, we overlook the 4-chamber signs and then we miss the diagnosis. Or there are abnormalities that cannot be detected by mere 4-chamber view, and we don't do the other extra views. So first reason why we miss abnormality in 4-chamber view, where 4-chamber view fails in screening the fetal cardiac, is an inadequate examination. This inadequate examination we can divide as an operator, because of the operator or because of the machine and technique limitations. So what are the operator reasons? It is because of the lack of confidence and apprehension about the fetal heart examination. This is very important. We as an obstetrician often fail to take responsibility of looking into fetal heart, and we feel, no, it's very difficult. And even though we do that, we try to get it from an expert. There is no reason to refer for an expert, but unless we take an responsibility to report this as a normal, will not learn. The learning curve will be too long. So we need to have confidence in ourselves, but for that we need to dedicate time for the examination. So if I tell, okay, I don't have, in my basic practice, I have to see 100 patients. So I don't have time to look into fetal heart. That it's not pardonable. It's not justifiable. Better you don't do that, and then you refer that patient. But what I would say, if you look into fetal heart, these are very simple things which we can pick up if we dedicate extra time. What will happen at the end of the day, if you see 20 patients and if you pick up some abnormality, you may not come to the diagnosis, but you can pick up that something is wrong in fetal heart. At the end of the day, believe me, you will be very happy that you could do the ultrasound, you could do fetal ultrasound, and you could pick up some abnormality. So this is how that will encourage you for more and more interest into the fetal echocardiography, or at least for screening the fetal heart. And the lack of expertise, we obstetricians, we often are behind taking our accreditation for NT certification and NFLID certification, but we don't have such type of certifications for fetal heart. Our societies like AMOMS or our FOXY, they can start such programs where they can certify the practitioners to look into the fetal heart, to screen the fetal heart. And unless we do that, unless we audit our images, unless we have a certain level of certification system, our expertise will not improve. So these are the operator dependent causes for the inadequate examination, whereas machine dependent or technique dependent, they are the high frequency transducers are very much needed for the detailed fetal and appropriate fetal heart views to achieve. We need to have machines with a Doppler, Cineloop facilities, and we need to have good pre-sets for fetal echo. Nowadays, all of us are doing Doppler, all of us are having good machines. It's like a mobile phone. We used to have simple Android phones, and now we can't imagine ourselves without smartphones. The same way we are now opting for more and more higher end machines with the Doppler facilities, and all these Cineloop facilities and presets are available. We need to spend some time with the machines. We need to play with the knobs and buttons of the machine. Definitely, it's a time-consuming process for initial few years. Once you get into that, believe me, it's hardly a matter of segmental sequential analysis of fetal heart. Hardly takes 1 minute to complete if heart is in a proper position. It's an immensely pleasurable thing to look into the fetal heart. Second reason is inadequate examination. What happens many of the time, we see frequently reported reports as the limited examination due to improper fetal position. When the fetal position is not proper, like in this video, is the video see? Video is see?
Yes, ma'am. Yes, ma'am.
Yes.
So here, what is happening? The spine is here laterally, and the ribs are casting shadow over the fetal heart. And if we try to report abnormalities, we try to look into the abnormalities in this fourth chamber, or if we try to look into this fourth chamber, it's not a way to do that. It is going to definitely demoralize us. So what I would advise you, if this is the position, just finish up. Close the examination. Ask her to roam around in your OPD, come after half an hour, or have a lunch and then come again. And when the spine comes posterior, that time you start doing fetal heart screening. But remember, never do fetal heart examination in such views where spine is anterior or late gestation where liquor is not adequate. When you are started learning into the fetal echos or fetal screening of the heart, that time you see that the spine is always posterior, the gestational age is mid-gestation, and placenta is posterior. moderately obese patients, thin patients. In such cases, you try to learn and do the things. Look into the 4-chamber view, because this is going to help you to extend your potentials. Okay, once you start looking into the 4-chamber view, I'm confident that you will not stop there. You will have more active, more inquisitiveness to look into the other details of the fetal heart. So this is how you have to start your journey to look into fetal heart. 4-chamber view examination should not be just the counting of 4 chambers. So this is I'm doing, okay, see, 4 chambers are seen, few details are seen, septum is seen, okay, fetal heart normal. This is not excusable. So we cannot afford to miss important details in 4-chamber view if the examination is, fetal position is not proper. Better wait. As I told, auditing for aneuploidy markers and anti-certification is always a major concern for us than for having a certification or for having training to look into the fetal cardiac assessment. So examiner is not able to obtain the 4-chamber view in this way. Spine is completely at 12 o'clock position. Image is not optimal. Whole spine and ribs, they are casting shadow. Never try to report and try to stretch your potentials to look into the details of the fetal heart. Let the baby turn around. You cannot complete fetal heart examination in a single sitting. You should expect that you may need 1 or 2 sittings, and accordingly you have to tell your patients. And one important thing is you have to tell your patient that sometimes some fetal positions are not favorable, and this much time I will need to do fetal echo, or this much time I will need to do your ultrasound. But because if we go on doing and trying for the fetal heart abnormalities to pick up, what will happen? The patient will get tensed up and she will try to contract her abdominal muscles, which is again going to impair the visualization. So before you start your ultrasound examination, explain the procedure to the patient that this much time I'm going to take, and see and show her. See, this spine is anterior, it's casting shadow. I am not able to look into the fetal heart, and unless I see honestly what is occurring in the fetal heart, I will not report. So, do you want me to report this without having a proper view? Then definitely patient will accept. They'll come back, and you can call her for the next meeting. So the solutions to overcome the inadequate examination is optimum time for fetal heart examination is ideally 18 to 12 weeks. Once you achieve a good level of expertise, you can bring down, you can look into the smaller hearts like 16 weeks or at the NT scan, or even at 10 weeks with good transducers like transvaginal transducers, you can pick up a good number of abnormalities even at a NT scan level. So magnification of fetal heart is very important. Your screen of ultrasound machine should occupy about 2/3 of the screen. Don't try to look into the details with a small heart. You try to maximize, but how to maximize, we'll come to do that in the future for the slides. Important is the cine loop is very important. You try to assess the movement of AV valves in different phases of cardiac cycles like systole and diastole. Are they opening and closing properly or not? How is the opening movement? So this is how we need to look into that with the help of the cine loops. Wait for spine to be in the posterior or at the 6 o'clock position. So that time heart will be at 11 o'clock position. So heart having at 11 o'clock position, never lose an opportunity. Try to see maximum things in 4-chamber view, irrespective of your gestational age. And this is how you will going to improve your learning skills about the fetal cardiac. You can reschedule the examination if the position is not proper. You need to mention the difficulties in the examination. It's very, very important, because this is going, this patient will go to some other consultant, and that consultant should know what difficulties you face during examination, like high maternal adiposity. And you can that time mention that the fetal screening of the cardia was done in high penetration mode, whatever it is, or transvaginal examination. So these, or if you are not able to pick up, you can take in help for the fetal cardia from an expert. But that time you just mentioned the fetal position was not proper, and maternal adiposity was there, advanced gestation, oligoid failures. These are all limiting factors. They are important, but you have to mention them in your report. And second thing is that if you are going to reschedule your examination, it is your responsibility to rescan that patient and give the complete report. So you can tell, okay, this is my responsibility. I will not release the report unless I see heart in a proper position. So this is a very, very important message we need to give to our patients. At that time, they will feel really doctor is also looking into the fetal heart very honestly. This is going to reduce our litigations for fetal ultrasound. That is going to increase the level of confidence the patient will have in us. There are various it's available on the machine, and these are the very important optimization techniques for the fetal echo, like depth, not fetal echo, even for screening the fetal heart. So like the depth of the image, then sector width, zoom box or pan zoom, high frame rate, and use of harmonics like SRI and CRI. See, we are always scared for looking or changing into the presets. I will lose. But what happens now? Like a mobile phone, we never used to be well versed with these Android or smartphones, but we started playing with the phones, and then we started looking into more and more features of the phones. The same way, we need to play with the machine. Don't be scared of losing your presets. Your application engineer has to be there, and he will also be helpful. Nowadays, with the team share, they can advise us online also. So just try to do things and change the presets, or just try to see the images with different techniques, and then only you will learn which is the proper technique, why it should be so. Because we tell you follow, that is not the way. You have to get convinced to experiment yourself. Why? What is the problem? What is happening if I reduce the sector width? What is happening? What is the depth? How is the image resolution? It is improved or not? What happens if I reduce the PRF? What happens if I increase the PRF? PRF means pulse repetition frequency or high frame rate, which is very needed, which for the heart. Heart is an organ in motion. So what are the changes which are occurring in one cardiac cycle? We need to tap those changes, and that's why we need to increase our frame rate. Frame rate means the images which are taken in 1 second. More the frame rate, more the images our machine will acquire. So this is coming to the one important point, like a depth. So when we put our transducer on the maternal abdomen, what happens if the mother is obese? What will happen? The heart will lie down at a very long distance, and the time taken for these waves, ultrasound waves, to reach to the fetal heart and come back and display on the monitor is going to be little more. And what will happen? By the time we catch some systolic change, the diastolic will be lost, isn't it? So what will happen? What we have to do? We can increase the frame rate, but how can we increase the frame rate? We can reduce the depth. So this is how the depth is reduced. I have brought this image by reducing the depth near my transducer. So the time taken for ultrasound waves to travel to this fetal heart is relatively small, and this is going to pick up more changes which are occurring in the one cardiac cycle. So frame rate is also called as a temporal resolution. It is increased by reducing the depth, as I told you. Reduce the depth will increase the frame rate. Second, sector width is also important, or sector size is important. And third is lowering the line densities. Coming to that, what will happen? It is the sector width. So for all the organs which are lying in such a big sector, it will take some time, isn't it? So little more time will be needed for my transducer or for my machine to catch the changes which are occurring in this whole area. Sometimes what will happen? My heart is only in these small areas, and all these extra areas we don't need. So at that time we can reduce the sector width. Just bring your heart in that minimum sector width. That is going to increase your frame rate, and that is going to help us for the better temporal resolution. So this is also a line density. Again, reducing the line density will increase the frame rate. Reducing the line density will increase the frame rate, but little resolution will be compromised. So line density generally we need not touch. This is there in the presets of the echo. So important thing is reducing the sector width and reducing the depth of the ultrasound beam. So this is a small demo. What we can see here is this is scan for 13 weeks, 6 days. What I'm doing, this is the normal sector weight. But I have reduced the sector weight, and as I reduce the sector weight, what will happen? My PRF rate has increased. Okay, so then what I have done, I have just put the box and then I have zoomed that. So what was happening is, we'll just repeat again. So this is at the depth of 11.8 centimeter. And what did I do? I just reduced the sector weight, put the box, and now the depth has reduced. It is now 7.5. So the quality of the image and the details of the fetal heart you can very well make out at this 13 weeks, 6 days. So this is how you need to experiment. Unless you experiment in a very favorable patient, thin patient, transvaginal sonography, and you have time to spend with the machine. So these changes will give you confidence in doing normal cases. So whenever an abnormal case will come, that time you will be able to use all these spray sets with confidence. So use of the color that too in dual mode is very important step. So what happens, unless we use the color, we'll not be able to pick up small VSDs. And this is one of the reasons, while doing hundreds of scans, if we don't, in a hurry, we don't have time. Many of the times we get an answer from sonologists that, see, we have to do 100, 150 scans. So where is the time to put the color in fetal heart and see? And there's such cases often come to me. She came to me at 36 weeks, 6 days as a first visit. And when I just do, my strategy is that I will do my first scan of my own. So when I used this color, then I could see that there was a small VSD. It's very difficult to counsel this patient how this was missed in previous instance. So this is very important. You use the color. If your sonologist or if your doctor to whom you refer, they don't use the color mode, you can just request them, you just get me the 4-chamber view in grayscale, and you just get me the 4-chamber view in color scale. So that will reduce the chances of missing the such important VSDs. So this is one technique where this is my practical experience. The whole maternal abdomen should be used, for insunating from various angles. Our aim is ultimately I have to get maximum information from this patient, despite of some limitations. I know the 3rd trimester scan, it's very difficult to get anterior placenta, anterior spine, ribs casting shadow, less amount of liquor. This is definitely going to pose a lot of difficulties for you. So you can just bring transducer from this side. I am able to see the LVOT here. From this side, and I have just taken the transducer from this side, lateral resolution, lateral 4-chamber view I am seeing, and I am able to see the complete intactness of the ventricular septum. So this, I have just changed the direction of my probe. Now I have changed this direction, I have come from different angle, and I am now taken the basal 4-chamber view, I am looking into the pulmonary vein. See, this case, I am not able to document all the features in a single view. That doesn't matter. If you are seeing your patient in 2nd trimester, that's well and good. But try to always see fetal heart in all the trimester all the time. Okay, so this is basal 4-chamber view. I could see that pulmonary veins are there entering, so ruling out major pulmonary venous abnormalities. And then again in color, I'm just putting the probe, changing the transducer direction and getting the information. So in such 4-5 steps, we'll be getting the important examination which is expected from 4-chamber view, though not in a single. But that way, at least I'm convinced. See, these things I have not missed. So these small clips you can say, or small images you can say, and include in your report. So we know that there are 3 types of 4-chamber views. So first is apical 4-chamber view, where my transducer is coming. I'll just use the pointer. So this my transducer is coming from this direction. So I am able to see the apex of the heart here, and I'm able to see which is the right ventricle and left ventricle, because my transducer is able to see the apex of the heart. Is there any change in the apical apex? Is there any change in the axis of the heart? So this is apical 4-chamber view, which is very important. Second is basal 4-chamber view, where I am going to look into the pulmonary veins. At least 2 pulmonary veins should be seen in 4-chamber view, like right pulmonary and left pulmonary and right pulmonary veins. I am able to see and then entering in the left atrium. So this is basal 4-chamber view. And for interventricular septum and interventricular septum intactness or breaches in interventricular septum, we need to see the lateral 4-chamber view. So here we can just put the color and see is the septum intact or not. In some cardiac patients, we need to see, especially in the third trimester, because third trimester gestational diabetic or patients on insulin, patients for insulin dependent diabetics, the septum thickness will be more in them. So there are studies which show that the septal thickness is more in diabetic patients. So this is how we can just include more and more points in looking into more and more details of the fetal heart and maximum information. So this is a checklist which I offer to all our trainees who come to our hospital for training, and this I give in a calendar type format to paste them in the sonography room besides the machine. So when you get 4-chamber view, always try to get in a clip, not as a still images. It's very important, because if you don't have time later, and you can visit and see did I miss anything. So these are the checklist we have. We cannot bypass any point in this checklist. This is very, very vital information. You cannot bypass anything. So when you are convinced that all these points are there, then only you should shift to the next view. So these points are very important. And you just make your list, checklist, put them besides your machine, and initial few days you just follow them. Ask your assistant to tell is anything left behind. She will guide you. And once you are used to this technique, you will not need this checklist, because that will become your habit. So sometimes what happens, there can be discrepancy which is not very much apparent. So that's why these Z scores, they have come in the fetal heart biometry. So I feel the right side of the heart is abnormal. The other person may not feel, or physiologically also right side of the heart is bigger than the left, isn't it? So that time, these Z scores, they are going to help us. In 4-chamber view, various parameters are there, like left ventricular diameter or right ventricular diameter, mitral valve annulus, tricuspid valve annulus, the length of this chamber. So all these Z scores, as we know, we count for other parameters like osteoporosis, -2 or +2. Beyond that, they are abnormal. So your machine, nowadays machines, they do calculate these Z scores. If not, then there is a perinatology.com website where you can include your gestational age and these parameters. That will give you the Z score. These are very important, because some lesions like aortic stenosis, they are evolving lesions. We cannot take a decision at this time how this baby will behave in future. Will that baby will require immediate neonatal support or cardiac support? So for this, we can tell to the patients, you see, last scan this was this, now this has fallen to this, so that disease progression is a little becoming serious. So we can pick a call and refer these patients for a reference centers where she can be taken care, and even the baby can be taken care well. So this is a case of aortic coarctation. See, this is the right side of the heart, and this is left side of the heart. Not very apparent here, but still we can see that left ventricular diameter Z score was -4. That means left ventricle was smaller. Because I say that doesn't mean this is a evidence-based practice. You know, we are now in the era of evidence-based practice. When your report says that this Z score is -4, that it is conclusive evidence that there is really a left side of the heart is smaller than the right side. Then when we took the aortic arch view, you can see this aortic arch and this neck vessel, and there is a small narrowing of this arch, and you can see this balloon type of structure here, which is post-stenotic dilatation of the aortic arch. And this is a bicaval view, which is a luxury in this high-end machine. So bicaval view also is showing this aortic arch view, whereas at the same time it is giving me 3VT view. Can you appreciate? So 3VT view, we are showing this dilated ductal arch, and this is a narrow aortic arch with a flow reversal. So this is how these techniques are going to help us, and the 4th chamber is going to help us to incorporate more and more details in the view. The solutions to learn these techniques about the fetal heart is that pictorial diagrams of various cardiac abnormalities during our training programs can help us. We can just show which type of anomaly this is. Actually, this is spine, this is aorta, so this has to be left atrium, and this is left ventricle. So the left side of the heart is smaller, whereas this is right. So there is some problem in left heart, left hypoplastic heart, or there can be aortic stenosis, coarctation of aorta, like this. Or this is a pictorial diagram which says that left heart is okay, but right heart is smaller here. So something is problematic in the right. What are the conditions which will lead to that? Again, here we can see both the ventricles are normal, but when we see the attachment of the valves, here we can see mitral valve at normal level, but the tricuspid valve is placed apically. So it's an Epstein's anomaly. So this type of pictorial presentations and charts, if you paste in your ultrasound room, they are also going to help you in your initial days of the practice. So this 4-chamber view is very vital view, and there are a lot of potentials, lot of information we can get from the 4-chamber view if we get a proper 4-chamber view. These are like abnormalities of the myocardium or myocarditis or cardiomyopathies we can pick up. Or is there any pericardial effusion that can be picked up from 4-chamber view? Are there any abnormalities in the pulmonary venous connection? It's very difficult to miss. I mean, it's very common to miss pulmonary venous abnormalities, which is serious condition. So these abnormalities we can miss if we overlook the entrance of pulmonary veins in the left atrium. So this is how the abnormalities of venous connections can be seen. Are there any abnormalities of foramen oval, or is there any azygous vein which is seen in 4-chamber view, or there are any abnormalities of the rhizome? This information we can get from 4-chamber view. Remember, these are the things we should never miss. We cannot afford to miss on 4-chamber view. These are the cardiomyopathies which we need to diagnose. Then like rhabdomyomas. Here we can see. Okay, the video is not playing. So this is 4-chamber view, and this is here is the spine. You see the left atrium is completely concealed by an isoechoic mass, whereas this is right atrium, this is right ventricle, this is left ventricle. This left atrium is concealed by this mass, and this is rhabdomyoma. This was seen in 3rd trimester as a surprise. So HRHS, hypoplastic left heart, hypoplastic right heart, AVSDs, and Epstein's anomalies. These are the 5 anomalies. Remember, we cannot afford to miss on 4-chamber view. But that doesn't mean you should get scared for missing this abnormality. Once you are confident that my 4-chamber view was normal, and if somebody else reports, then you should be confident that no, I cannot miss because I have looked into proper 4-chamber view, and by default you will rule out all these 5 abnormalities if you are very perfect in taking your 4-chamber view. The reason for other reasons are cardiac checklist. Even though you are getting a good 4-chamber view, if you don't have time, you just count the tumor, see 2 to 3 points, overlook the checklist and report. So there is a chance that you will miss the abnormalities. You cannot afford to do that. Most commonly picked abnormalities in 4-chamber is asymmetry of the fetal heart, and most commonly missed is the area behind the left atrium. It's very important. That's why the entrance of the pulmonary veins is most commonly missed. I get reference for second opinions and third opinions, and all the time I feel these are the areas which are often overlooked. Maybe the lack of expertise, or maybe the machine limitations, maybe the I don't want to blame, but these are my observations. When I study what are the indications for referral for fetal echo, then I have come to this conclusion that this is the area which is often most common indication for referring fetal echo is echogenic focus in the cardia, and second is asymmetry of the fetal heart chambers. So heart is examined only in grayscale sometimes, and color is not used. You are going to miss small VSDs. So even TAP, we see abnormalities of the pulmonary venous drainage, they are missed by the experts if we don't look into the proper basal 4-chamber view. So again, this is the same different patient where color was not used. 4-chamber looks to be very normal, but there is a VSD which can be picked with aliasing across this interventricular septum. So no cardiac examination is complete without 4-chamber. Remember. Third reason is anomalies which evolve, as I told you, in third trimester. So valvular stenotic lesions like coaptation of aorta, they progress in third trimester. So you cannot expect them to get diagnosed in second trimester. Even TAPVCs, cardiac rhabdomyomas, cardiomegaly may be functional or cardiomyopathies. We cannot diagnose them. I mean, most commonly they are the third trimester diseases, which of them. Some forms of coaptation of aorta and septum, secundum, ASDs and patent ductus arteriosus, we cannot detect them in prenatal life. So we have to report in our fetal echo report also. Okay, these are the things which cannot be detected in prenatal. You can write a line on your report. So others are anomalies with normal four chamber, as we have discussed. There are abnormalities where four chamber view will be absolutely normal, and these are the transposition of Brit arteries. Of course, only D transposition. Whereas in L transposition, LTJ, you will have abnormalities in the four chamber view. So other abnormalities like tetralogy of Fallot, double outlet right ventricle, truncus arteriosus, and interruption of the aortic arches or arch abnormalities, you cannot diagnose by mere four chamber view. So this is the limitation for four chamber view for diagnosing these abnormalities. So solution for it is to incorporate extra views into this sequential screening of the fetal heart, as we see from situs, we just go Kefala and incorporate all those 5 views. And this is, I told you, this takes hardly 1 minute to incorporate all these views if fetal position is proper. So there are certain clues on four chamber view which we need to pick up, like situs, where is the heart, which side. I am not going into the details. So this was also a small case I will share. Here there is a situs solitus. Stomach is seen here. Stomach is seen. Gallbladder, instead of in the right heart, it was in the center, but heart was directed on the right side. And when I went through this four chamber view, the left side of the heart did not have flow. That means mitral flow was not seen. And then this IVC was entering, SVC was entering, so systemic veins were normal. And this was a case of the heterotaxy, right heterotaxy, means right-sided structures were repeated on the left side. So left side structures like spleen was absent, heart was on the right side, liver was in the center, and this left side lung will be 2 lobes and right side has 3 lobes. So right heterotaxy. So all the 3 lobes were seen on both sides, right and left. So and then this was the right side of the heart, left side was mitral atresia was there. So this was a confirmation, postnatal confirmation. So this dextroposition, mesoposition, leoposition, these are the clues which will tell you. Okay, you look for more and more details of the other heart views and come to the diagnosis. This is like signals for us to look into the details. So clue like cardiomegaly. So if you see cardiomegaly, so we need to look into some cardiac causes or extra cardiac causes, which I am not going into details because of the time constraint. So other clue which we can take from fourth chamber is left axis deviation. So we need to measure the axis, or eyeballing is also enough. When we see that there is extreme left axis deviation, you should get an alarm. Your antenna should raise, and you should feel that I should rule out tetralogy of Fallot, common arterial trunk, or coaptation Ipstein's. Or if there is right side axis deviation, we should now look into extra views and rule out these conditions like double outlet DORV or AVSD, atrioventricular septal defects, or common atrium. So these clues we need to pick up from our fourth chamber view. So this is one case where she came to me at 33 weeks, and this was the video is not playing. Okay, but what the fourth chamber view was okay, and I could see only one vessel arising from both the chambers. This video is not playing. Okay. So at 33 weeks, you imagine she was a dentist and she came to me just casually. But because only four chamber view was normal, other views were not incorporated, it seems the serious diagnosis of common arterial trunk was missed at 33 weeks. She was dentist. Her husband was an orthopedician. Her co-sister was obstetrician in AIMS, Delhi. And then she delivered there in AIMS, Delhi. And baby was operated for common arterial trunk, but they could not save the baby. Picture is so this is how this four chamber view was normal, that was not picked up. Other views were not incorporated, and we missed the diagnosis. So this is how our responsibility is to look into the fetal heart at all times, and especially for chamber view. And if you are expert, then look into more cardiac views. Here you can see a common vessel which is arising, being contributed from right and left ventricle, and color also lot of aliasing for a single vessel arising from both the chambers, coming to the diagnosis of common arterial trunk. So as I told you, area behind the heart is also going to help us. What is the distance of left atrium from the spine? What is the aorta here? So it is very simple thing. So aorta should be long, just adjacent to the left atrium. If aorta is not seen on the left side, sometimes you may say aorta in the center, or you may say aorta in the right side. It is so simple. The right aortic arch can be diagnosed by this chamber view. So if generally right aortic arch is associated with conotruncal abnormalities. So when we see, oh, aorta I am not seeing on the left side, it's from something shifted to the right side, then obviously you will be more careful in looking into the 3VT vessel view. So this is how we need to look into the area behind the heart and location of the heart. So this is also one case where this is the right side of the heart, this is left side, and this is one extra vessel is seen, azygous vein is seen here, because generally there should be only one vessel behind the left atrium, and that is a descending aorta. If you see some extra vessel, then you should suspect why there should be some extra vessel, and it is to the right, so it is azygous vein. So 4-chamber view was normal, other views were normal, and to our surprise, but that is bicaval view. We should be, once you are expert in 4-chamber, you incorporate other views. So when bicaval view was incorporated, we could see that the inferior vena cava was not seen. Inferior, this is descending aorta, but inferior vena cava was absent, and this was a case of absent inferior vena cava with azygous continuation, or interrupted IVC with azygous connection, because this is not a lethal abnormality. The couple continued the pregnancy, postnatal confirmation was done, and this was done, scan was done, and it was this MR angiography was advised for that baby for having this interrupted IVC with azygous connection. This baby is doing well, and there is no any problem for the baby. This is a postnatal picture, but baby is now 2 years old and doing well. So this is how, when we are very honest in or incorporating all the views, it's very less likely that we miss such abnormalities. This is also one view where 4-chamber view is seeing, and we can see the aorta here, but relatively right side of the heart is looking a little dilated, you know, and there is this is LVOT view where you can suspect the this tetralogy of Fallot, where we can see perimembranous VSD, and here we can see this was the umbilical vein which was directly draining in the right atrium, bypassing the ductus venosus. So ductus venosus was not there, and this is how we could pick up with the left axis division, and these were the clues. So this pregnancy was discontinued and autopsy was done, where you can see this is umbilical cord, and when we negotiated a rod through right atrium, that this rod was directly going in the umbilical cord, bypassing the ductus venosus, which enters the liver, and then it along with IVC it enters the right atrium. But here what is happening, the umbilical vein is directly going into the right atrium rather than going in the liver. So this is how this was a case of ductal agenesis along with tetralogy of Fallot, where we can see dilated aorta and small pulmonary artery, and aorta is overriding and coming to the anterior. So dilated coronary sinus also we can see on 4-chamber. So this is very important view. This is 4-chamber, and if you see cystic structure in the left atrium, your suspicion will raise, and this is the dilated coronary sinus. Why that should be dilated? Generally, dilated coronary sinus is associated with the left persistent superior vena cava. We have 2 superior vena cavas, but only right is there and left is not there. Left undergoes regression. So if that is also present, then that extra flow from the fetal head will be drained in the coronary sinus, and coronary sinus will be seen as a dilated structure. Measurements of coronary sinus are also available. We need not do that, but eyeballing is enough, and we can see that dilated coronary sinus, suspecting the left persistent superior vena cava or other is coarctation of our aorta. So we can help. This can be this is coronary sinus is the venous drainage of the heart, where it enters from left atrium to the right atrium, just in the groove, interventricular groove. So this is a venous drainage. So when there is an abnormality or enlargement in this coronary sinus, which we can pick up from four chamber view, these are the possibilities. Mainly, very serious is the coarctation of aorta. And because left persistent superior vena cava is a benign condition, it may not trouble the baby's life. So important is coarctation of aorta. So how to, and one apart from that, important is the AVSDs, atrioventricular septal defects. Where four chamber view is best to diagnose. And what are the tips for diagnosing AVSDs or endocardial Cushing defects? It's that AV valve should be seen both in systolic and diastolic. That's why we need to use cine loops. Always see cine valve movements. Are they opening or not? And look for the offset, which is very important, because the tricuspid valve is inserted a little apically, and there is a gap, a very small gap between the mitral valve and tricuspid valve. And if that offset is absent on four chamber view, you have to have doubts. Is this AVSD, or there is a linear insertion of the AV valves, which should be ideally, there should be a little gap between the two. But if they are at same level, then this is one of the markers for doubts. And we have a case where there was only linear insertion, see, nothing else. The couple opted for amniocentesis, and it turned to be T21 case. So this is how these are small subtle defects which you overlook, you can be in trouble. And color Doppler is also very useful in diagnosis of AVSDs, where we'll see the single jet of the blood entering as a single channel of blood in AVSDs. We'll be able to see, pick up, and the color Doppler will help us for coming to the diagnosis. So because mitral regurgitation is rare in fetus, so when you see a lot of regurgitation across the mitral valve, always suspect AVSD. Maybe it is a partial or complete. We'll not go into details. One important point for four chamber view is sometimes if our plane goes a little behind, I mean little posterior, then this view may come. So this is four chamber view. You can see the crux of the heart, and this is a septum primum. But if your transducer is cutting the heart at a little lower level, what will happen? It will go at the level of the coronary sinus, and you will miss the septum primum. And this is actually the coronary sinus. This is left atrium, and this is right atrium. This is normal. But if you are commenting on this four chamber view, you will comment that the septum primum is absent, and it's a case of AVSD. So be careful. If your baby is there like this, change the direction, take other views, four chamber views like basal chamber or lateral four chamber, which is very useful for documenting the septum primum. And this is a clip where you can see this septum primum is not seen because your view is little posterior. So this is very important to see. So HLHS, this is one case where we can see that there is asymmetry. Left side of the heart is small, right side is dilated. This case was referred to me as a case of HLHS and bradycardia. And she was advised fetal cesarean section at 36 weeks for fetal distress. And when we did her scan, we could see that the foramen oval is so much big that it's occupying complete left atrium, and it's mechanically obstructing this flow across the mitral valve, and that's why what happened, there was a less flow in the left side of the heart, whereas the right side of the heart was dilated. And this case was a case of aneurysm of foramen oval. It's very simple. Anybody will tell you this foramen oval is very big, isn't it? It's not, you don't need very high skills to come and pick up these small things in four chamber view. You don't need any high level of expertise, but only thing you need a lot of motivation and time. So this case was a case of aneurysm of foramen oval, and but what happened? She went to other government hospital, got delivered, but called me and then told the baby is nice. Then I was very happy because this was a benign case. Otherwise, HLHS will have a very bad prognosis, isn't it? Whereas foramen oval is a benign condition. So this is going to change your management, isn't it? So this is how this type of foramen oval aneurysm we need to have in mind when we are especially doing fetal cardiac screening in third trimester. So remember, when you see small heart on left side, look for foramen oval, how it is. Is it dilated? Is it occupying the majority of the left atrial area? This is how we need to confirm. This is also a big baby and doing very well and was saved. This one patient, third trimester surprises. I have told all the second trimester scans were normal. Patient insulin dependent diabetes, and third trimester is the old picture where you can see the chamber hypertrophy. You can short axis view. We can see almost nothing is seen in the ventricular chambers. So this small amount of chambers and only the hypertrophy can be appreciated. This interventricular septum was very thick. This was a chubby baby of this diabetic mother. But remember, these babies do well and these hypertrophic changes come down in postnatal life with a good follow-up. So recent case, this also is small, interesting case where you can see this is a 4-chamber view. Your chambers are normal, but see what is happening. There is a flow from this right pulmonary vein. It's going here and then entering the coronary sinus. So this is a mere 4-chamber view diagnosis. You know, if you are very keen in looking, so you can see that coronary sinus is here is dilated and that pulmonary vein is normal, but right pulmonary vein is directly going here and going reaching the coronary sinus. So this was anomalous pulmonary venous, but partial anomalous because left vein was normal. This was right pulmonary vein. You can see in rendering mode. Here coronary sinus, you can see coronary sinus is dilated, and that is the reason. And this is the view where you can see this right pulmonary vein is directly going in the coronary sinus, and that's why right side, because coronary sinus will drain blood from left atrium to the right atrium, and that's why right side of the heart is dilated. Here you can see directly from in this picture, this pointer, this is the right pulmonary vein, which is going in red color and then coming back into the coronary sinus in blue color and draining in the right atrium and going to the right ventricle blood. So this is how, this is a partial pulmonary venous drainage case. So this is diagnosed only with a keen observation on the 4-chamber view. This is nothing very creditable. Once you are into that, you will catch up such cases. Take home message is that my earnest desire is that even at the end of this lecture, if 1 or 2 of you get interest to look into the fetal heart, I will be succeeding in my motto of motivating the obstetricians to look into the fetal heart, you know. And this is because I love this, elevate yourself. Uddharedatmanatmanam. This is a very important shloka from Gita. Never underestimate yourself. Never underestimate your potential. Because your mind can be your friend and enemy for yourself. So always be motivated and look into the fetal heart in all scans. This is my message, and I will be very happy if you start incorporating these views in your practice, though a little busy for obstetrician, but this is going to give immense pleasure at the end of the day. I'm very sure. Thank you very much. Thank you for a little more time I have taken, sir. But I'm very happy that I could get a platform where I could share my experience and pleasure with you all. Thank you very much.
Great, Megha madam.
Excellent talk, madam.
Excellent. It is far more than excellent. Ultimate videos and great pictures and the explanation too. Very nice one. Thank you very much for the great.
It was really excellent talk with all practicals and video presentation means we get all practical experience, and it was a really excellent talk. I think this time is also less. We should keep. Now we are thinking again separate slot for you.
Megha madam. अगदी शिकवण्याची तळमळ दिसली तुमच्यामध्ये.
अगदी from the bottom of the heart you were talking.
Yes.
Really one of the best lectures.
I get tears and my फक्त मला असं वाटतं की अरे मी करू शकते तर मग सगळे जण करू शकतात ना.
Yes.
Why should we depend on others? We can improve ourselves. असं नेहमी मला वाटतं.
तुम्ही अशी म्हणालात की त्या गाण्याच्या मैफिलीमध्ये माणसं कमी आहेत, पण ही फक्त फॅकल्टी आहेत. ऍक्च्युअली लिंक वेगळी आहे.
एक्झॅक्टली. डेलिगेट लिंक वेगळी आहे.
ही फॅकल्टीची रूम आहे मॅडम, तिकडे आहेत 100
माझं मी खरं सांगू का, मला त्याच्याबद्दल एवढं नव्हतं, पण जेवढ्यांना मला मेसेज देता येईल तेवढ्यांना देता आला तरी माझं
परत एक अरेंज करू मॅडम तुमचं आणखीन मोठं लेक्चर. छान.
कार्यक्रमाची जी भैरवी असते ती खरोखर जबरदस्त करावी लागते आणि ती
Yes, yes. As
And you
Gaurav
are
sir
trying
said,
to tell technical
yes.
points also.
Yes.
That is also very important.
Madam, we all are artists. तुम्ही
aspect.
सिंगर आहात. गिरीश आहे ना आपला, गिरीश तो पण अल्टिमेट सिंगर आहे.
Yeah, I'm in his
तो
group. I'm in his group.
येस. आणि गोरख मंजुरकर आणि मी आम्ही दोघ जण ड्रामा आर्टिस्ट आणि डायरेक्टर आहोत.
So nice.
परदेशी सर रन्स म्युझिकल ग्रुप हिअर.
Okay. छान आहे.
आणि वैशाली गिरीशला नाचवते, त्यामुळे ती डायरेक्टर आहे. असे सगळे आर्टिस्ट एका ठिकाणी जमलोत. हे चांगले
स्टालिन, हॅलो
आणि आम्ही
स्टालिन,
प्रेक्षक पण आहोत बरं का
स्टॉप
चांगले.
स्टॉप लाईव्ह, स्टॉप लाईव्ह.
ओके सर.
मला
स्टॉप लाईव्ह.
माहेरच्या आज मी परत औरंगाबादकडेच होते. माहेरच्याकडनं
Sir,
खूप बरेच
I
जाणार
can't
आहेत.
stop live, sir. If I stop live, then the webinar will be closed, sir.
Okay, okay.
Okay, fine.
Yes.
Okay, fine. Officially, I convey gratitude to all the speakers, chairpersons, the delegates who are attending today's webinar, particularly Pardesi sir, Gaurav Bhau, Megha madam, then Amey Purandare, Manisha, who have given great lecture, and my co-convener Dr. Girish, and President Urashali, Zopate madam, Secretary, then Anuradha Shivale madam, Gurpreet madam, and the great educational support from Stalin and the Shield Connect. Thank you very much. So we assure you to meet again for a great academic feast. Thank you very much.
Thank you so much.
Thank you. Thank you
sir.
so much.
That was a wonderful session, sir. All the topics.
Thank you, Dr. Stalin. Thank you.
Sure, sir. Thank you very much, sir.
Thank you.
Bye bye. Good night.
Bye.
Good night. Stay safe.